A very warm welcome to another episode of eGurukul, where our beloved teacher, Dr. P.C. Mahapatra, he is going to continue with his sessions on various tips and tricks of surgery in gynecology. And today's topic is hysteroscopic surgery. So, Dr. Mahapatro had been very energetic in transferring his skills. Uh, his energy is, it motivates everyone. So, without taking much of your time, I would like to give this session to Dr. Mahapatro so that we can learn a lot more from him. Dr. Mahapatro, please.
Well, thank you, Dr. Diwan and the whole team of Juventus for the continuation of the program of eGurukul amongst our fellow gynecologists and all that. And it's really a pleasure on my part to be associated with this program. And I was stimulated by the viewers and the response and all my gynecologists across the country so that I'm continuing the program. In the meantime, we have almost finished 10 episodes. It was a real surprise when I look back, and 10 different types of focus aspect we have discussed. And I thought it's an end, but Juventus people didn't want to stop me. And that's why I'm really happy and really grateful to the Juventus, whole of the Juventus team for their effort and spreading the knowledge and sharing the experiences of mine to my fellow gynecologists, my colleagues, my friends, my students, my grand students, and all that. Believe me, with humility, I can tell that yes, we learn from our mistake, and surgery is a thing where you have to have repeated, I think, procedures and do it in a very meticulous way, not only to prevent complications, but to give a good result to the patient. Ultimately, it boils down to result. The greatest wealth of the professional, I always tell, is acquiring a skill. And that is the main purpose for which the skill is required. And with 38 and 40 years of experience in this profession as a gynecologist, I have done several mistakes, and I will just convey and share my mistakes to other people and my methodology of treatment and experiences for the last so many decades, so that the newer generation will get really boosted with this and do more innovative work, and they will excel the previous generation, including myself and all that. And with that purpose, we are continuing this program of the surgical skill transfer. And I here welcome all the viewers of mine to this eGurukul program, an innovative program of a teaching program, and episode 11, which is mainly targeted for the surgical skill transfer and solving the clinical dilemmas. Well, this time, I think again I pray, Lord, for everything, because beyond science, something related to the supreme is there, which we always respect and we always regards and we always pray. Well, this time I thought the topic will be mastering hysteroscopy. And mastering hysteroscopy, the tips and tricks, I think I will just narrate within a couple of hours and sharing my experiences with this. Well, there is no doubt that endoscopy has infiltrated every branches of medicine, including gynecology. And gynecologists are in forefront in terms of the endoscopy, and starting from the laparoscopy to hysteroscopy to colposcopy. There are various horizons of the scopy which has expanded its indications and the procedures. And over a few decades, I think there is a lot of advances by the technological advancement, by the improved skill of the gynecologist, and finding out new opportunities, a new arena in the field of gynecology in various places, so that one can boast himself or herself as a true gynec endoscopist when he or she will do everything. It's not limited or confined to the laparoscopy or a particular segment of the laparoscopy or a particular surgical procedure only. A gynecologist is not, I always say that a gynecologist is not a complete gynecologist without the knowledge of endoscopy. an obstetrician is not a complete obstetrician without the knowledge of sonography. I think these are the two hands of the obstetricians and gynecologists, which every gynecologist should master that. Unfortunately, hysteroscopy has not become very popular among the gynecologists because some of the people want that this is a very difficult procedure to learn. But believe me, it's a very easy procedure to learn, and I want all my gynecologists to be hysteroscopists. And there are various rewarding opportunities for hysteroscopy, both diagnostic as well as operative. Once you become really start the procedure, you're addicted to the procedure of the hysteroscopy for that. And again, I must say that the whole complete endoscopic procedures in gynecology, both hystero and laparo, are complementary to each other, and the tips and tricks has to be really born to prevent complications and maximizing the results, minimizing complications for that. Well, what is hysteroscopy? Hysteroscopy is not a new thing. It's old, 18th century, 19th century. I think there were a lot of advances. And this is just a visualization of the uterine cavity, hysteroscopy, to view the interior of the uterus and visualization of the cavity of the uterus and cervix through some equipment. And this endoscopic equipment has helped a great extent in this hysteroscopic procedure for that. There's been lot of advances since that beginning of this century. I think the evolution of hysteroscopy, when we look back, way back in 1805, this is the father of hysteroscopy, P. Bogini. Bogini was considered as a father of hysteroscopy. Before laparoscopy was born, hysteroscopy was born. And for few decades and 1 or 2 centuries, it was just dormant because of some obvious reasons for that. 1805, Bogini was an extraordinary visionary, and the curiosity is beyond human values and all that. So that's why he, due to the undue curiosity, he has a curiosity for exploring, for looking into the natural orifices, putting speculum into the natural orifices of the human being, and particularly the females. And for this act, the reward for undue curiosity is he has to spend in behind bars till many years, till the death he was being sentenced. And this is the sequence of events, not only of Bogini but any innovators over the globe. You find that innovators are put behind bars because some newer philosophy somebody points out. I think they're all prone to the criticism and legal problem for that. After 50 years, Desormex, as a urologist, he's come as a father of cystoscopy. He added how to improve this internal thing by putting into the speculum or by creating a new orifice. You have to find a light source. You cannot see in the dark and the vision is not there. And he was credited in formulating, giving the light source, transmitting from the outside to the interior. And that is a revolution in the field of urology as well as the gynecology for that. In 1869, you see, 1869, Pantaleone was the first man who introduced this hysteroscopy, an endoscope into the primitive endoscope into the uterine cavity of a 60 years postmenopausal lady suffering from polyp, and credited with the removal of the polyp in a postmenopausal woman. And that's why he was considered as a father of operative hysteroscopy for that. And since that time, lot of innovations, lot of researchers, lot of endoscopic surgeons across the globe, starting from Neech, Clado, Hopkins, and Palmer, and modern stalwarts like Lindemann, Hamu, Neuwirth, Goldrath, Dicheny, Bagis, Sigler, Daniel, Magos, Vitocci, Osama, and Dr. Professor Motasho from India. I think they are credited. They have spent a lot of time in the hysteroscopic procedure, not only in innovations, but for spreading the knowledge of hysteroscopy into the gynecologist's mind. Well, what is the difficulties? The endoscopic examination of uterine cavity is difficult. If you compare with the laparoscopy, the space is such that you can visualize the peritoneum, intraperitoneal contents by giving an hemoperitoneum. The margin, the wide views can be done, and it can be very well depicted by hip laparoscopy. But here the difficulty is, number one, entrance through a narrow passage very narrow passage through the cervical canal, you have to introduce your scope. Second most important, because the uterus is a very muscular uterine cavity, distension becomes a problem. If you compare the distension of the bladder or urinary bladder by the urologist, or the distension by the laparoscopy surgeon by the pneumoperitoneum, it's very easy, but difficulty in distension is there. And that for these regions, technical regions, the advances of hysteroscopy falls behind laparoscopy. Another important, that the bleeding from fragile mucosa, obscures the vision for that, and many other technical problems like the vision, the camera, the light source, the clarity of the vision, the distending medium, all these created hysteroscopy in a backbench than the laparoscopy for that. Now, the advantage of hysteroscopic surgery are related to the patient, to the physician, and to the payer. I think the patient, there is a really a minimal invasive surgery, concept of minimal invasive surgery is really met with by hysteroscopic surgery than compared to the laparoscopic surgery. Even with the office procedure in the clinic, many of the procedures can be tackled in the daycare procedure, and within hours, patient can be discharged for that. And for the physician also, it's very simple procedure and they can learn and practice this. And for the payer, ultimately the hospitalization is not there for a long period, and therefore the payer is also benefited for that. Now, coming straight away to the indications of the hysteroscopy, broadly I will divide into the diagnostic as well as therapeutic. You just visualize the cavity to diagnose some of the intrauterine pathology, and then initially that stays for a long time, and subsequently with the innovations in the technology and the different accessories and advances in the vision and the distension medium, and working through the very small uterine cavity, I think the therapeutic armamentarium has been broadened, and the scope of hysteroscopy has been really very big nowadays for that. Indications are now following the hysteroscopies for that. Now, the common indication of hysteroscopy is an abnormal uterine bleeding. Gone are the days when a blind D&C was there. For years together, gynecologists were doing a blind D&C and endometrial pathology for that. And now we have reached a stage that the high resolution sonography can be an aid to the procedure for that. But the real visualization, direct visualization of the uterine pathology cannot be compared with the other procedures, other methodology for that. Therefore, nowadays, for abnormal uterine bleeding, hysteroscopy is mandatory for that. Because many cases we find that presumed to be an endometrial hyperplasia, presumed to be a normal uterine cavity, and diagnosed as a dysfunctional uterine bleeding, or AUB, which is related to the non-structural. Now, by hysteroscopy, you can find that this non-structural lesion can be a structural lesion, and diagnosis from abnormal uterine bleeding can be shifted. It's not a functional, but it's a really a pathological thing. It either could be a small polyp or a myoma, can be detected inside the uterine cavity by direct visualization. Even in suspicious cases, you can do a directed biopsy. Even for hormonal, I think the basis of the hormonal basis also, you can do a curettage after visualization of the cavity and send it for endometrial study for the pathology to exclude either a tuberculosis or malignancy, or whether the type of endometrium, whether a proliferative, secretory, or hyperplastic endometrium, we can know that. And that's a positive correlation between histopathology and the diagnosed and the hysteroscopic appearance, and correlation is up to about 80-90% of the cases. And there are various procedures, operative procedures, which can be done through the hysteroscope, which is very rewarding. A polyp, a myoma, giving rise to bleeding starting from the adolescent to the reproductive age group and postmenopausal. I think these are some of the rewarding surgeries in minimal invasive surgery. You can do it with the modern gadgets, ablation and resection. Endometrial ablation and resection. This, I think there is a lot of controversy and debate, which I will discuss in later, but still I can say that the concept of ablation and resection came from what? Say it's the concept is very genuine, that Why do an unnecessary hysterectomy when the endometrium is defective? Why do a hysterectomy when the only endometrium is defecting, giving rise to bleeding, as for example in dysfunctional uterine bleeding, in hormonal, in DUB-O or DUB-E? I think there is no need of removing the blind innocent uterus and the cervix for that, because if endometrium is defective, remove the endometrium, and that's the concept basing on ablation and resection for that. So this resection, hysteroscopic resection, has been really alternatives like thermal balloon ablation, or some of the Faradic the other methods of laser or radio frequency ablation has been adopted for that. But the resection, we have done a lot of resection procedures earlier. There are some indications of resection: young age, abnormal uterine bleeding, not responding to medical management, patient is keen for conserving the uterus. I think resection or ablation could be a better option for that. And but there are some of the debates or controversies relating to the resection, and there are therefore it's popular for some period of time, but somehow it was not very popular till date. And this is also an option. I don't say that resection you don't do it now, but subsequently, because of the debates and controversies, we have really, many people are stopped doing a resection and adopting some of the other methods like the balloon ablation and radio frequency ablation for that, which is really more non-invasive than this the hysteroscopic resection, because it needs a lot of skill required for that. Now, second important group is infertility and recurrent pregnancy loss. Recurrent pregnancy loss and infertility is one of the major things for hysteroscopic evaluation, both in terms of diagnosis as well as therapy. The intrauterine adhesions, if you look into that, the cavity intrauterine adhesions, incomplete or complete, space occupying lesion, either a polyp or myoma. Congenital anomaly is starting from uniconvate to septum to various types of congenital anomaly of the uterus, proximal tubal block. I think these can be very well not only diagnosed but therapeutic also, proximal tubal block, and particularly in assisted reproductive technology. If somebody is going for IVF, you have to see the cavity. I think it's a very costly or cumbersome affair, and we have seen many cases where without visualization of the cavity, without knowing what is the cavity, you do the procedure and then land in miscarriage because of the septum and other intrauterine pathology for that. And therefore, now it's a routine that before ART procedures or IVF procedures, a cavity evaluation is absolutely mandatory for that. Either you can do a high resolution sonography, the 3D scan, but hysteroscopy is more appropriate than the 3D scan. And falloposcopy is another indication and a way forward and extension for the fertility management and fertility investigations for that. Now, the removal of foreign body, again, removal of foreign body. IUCD, I remember the lost IUCD or missing thread, but it's inside the cavity. We are doing long back by the X-ray was the only method, and then subsequently came as a sonography which can locate either whether it's a translocated or a displaced IUCD for that. And for removal, I think our teachers and including me also have done many before the era of scopy. We are doing a blind methodology of blind curetage, dilatation and curetage, and by filling that there is a foreign body, we just scoop it, and in 50% of the cases, it is not being removed and is left behind, and repeated procedure can give rise to more of complications like a perforation or Asherman syndrome or infection, bleeding, whatever is possible. But now, within seconds, you do the procedure and put a hysteroscope and find out and just to bring down the IUCD, remove the IUCD if it is left behind. Ossified product, cannula, tape, stent. Earlier, the lot of stent has been usually given, particularly for microsurgical procedures in the tubal anastomosis. No, now the indications are not very there. Stent people are not using it. Laparoscopic procedure is a better alternative. Without stent also, the recannulation can be performed. Now, sterilization. Many people have started looking for this sterilization as a method of sterilization, how to keep But remember, the God has designed in such a manner the fallopian tube that it's better to block the tube from outside than to block it from inside. It's very difficult to block the tube from inside, and many of the chemicals or very mechanical blocks, including Assure, has been tried for that also. And Assure by hysteroscopy, you do a hysteroscopy and fix it with that block. It is being practiced for that, but it's not very popular and effective method of sterilization because of the failure rate and all that. The failure are more. And besides this, the miscellaneous, the photodynamic therapy, and other broadening of the spectrum of hysteroscopy. We are day by day, we are increasing the indications of hysteroscopy. And I will show you some of the videos which I have experienced for the last so many years for that. Now, before going to that, let's find out what are the prerequisites for hysteroscopic surgery. If you are going for a hysteroscopic surgery, and particularly the therapeutic, even diagnostic also, there are some prerequisites. The counseling. Everywhere now, the people are educated. They consult Google Doctor before coming to you. And the counseling, the proper counseling should be done. What for what purpose should be there? And it's a participatory practice. Patient should know what is being done, and we explain that. That's very important. The tidbits of the hysteroscopic procedure should be done. If you're doing a office hysteroscopy, you must explain that office hysteroscopy without anesthesia will give it, and with little sedations or analgesics or antispasmodics. The positioning is really an issue for that, and many of the patients do not cooperate with that. So therefore, if office hysteroscopy has to be done, I think more of counseling is required for that. The patient should be convinced about the counseling part and the office hysteroscopy, which is now growing up, and many centers are routinely doing the office hysteroscopy for that. As far as my opinion is concerned, I'm office hysteroscopy. I have some reservations for that, because you find that office hysteroscopy diagnostic is all right. You can do it, and without the speculum, you can do a vaginoscopic examination, a vaginoscopic and hysteroscopy. But the main problem is that about the cooperation of the patient, the positioning. They are very skeptical about that, and even during the procedure of IUA also I have seen people are very really, women are very uncooperative for that, and therefore this is one aspect. And some of the minor procedures you can do it, not major procedures we can do it. And if you are doing it, even books write that the operative room is much better. You practice from operative room, then once you get that, then you can go for an office procedure. It's an adjunct to your procedure in some of the cases for that, because the dilatation is really a problem. You may fail to dilate also. If the position itself is a concern, and there are many factors. Patient factors are responsible, technical factors are responsible, and that's why this is really revolves around some of the debate. But still, I think it's growing. That lot of advantage is there. They can go without anesthesia. You can go away within a short period, go home in the office. But I consider there is an OPD procedure. Office hysteroscopy name has been given, and I feel personally that office hysteroscopy name is a marketing name for that. You are not an officer, doctor, medical officer, and doctor has a OPD. And OPD procedure, if you do an OPD hysteroscopy, it is not very popular. If you're doing an office hysteroscopy, I think it's a better terminology and gives some more of marketing and popularize the procedure for that also. It's my personal opinion. Now, pre-op evaluation, you must have to give an evaluation. Any procedure you do, the history, we cannot ignore our the clinical scenario and a clinical sense for that. Whatever technology is being developed, the tech and touch both has to be blended for that. And pre-op evaluation, it's a detailed history examination and the problem of the patient, and supplemented with it and non-invasive investigations like sonography. In all cases, in majority of the cases you do, and what for you are doing, you must know that the purpose for which you are doing it, and this sonography can give an additional value to your procedures for that also. So therefore, pre-op evaluation is important for that. Timing. One of the many important things is your timing. In which period of the menstrual cycle you do the procedure. I think the post-menstrual period is the best timing for that, because of the endometrium, because of the vascularity, and because of the secretions. I think the time is post-menstrual is the best period for that also. But even if the patient is bleeding, you can do with the bleeding procedure, because you can do an inlet and outlet and wash and all that with the double channel sieve. The clarity of the vision can be there if you are using the liquid medium for that. Endometrial preparation, if a hysteroscopic surgery, earlier we are doing a endometrial preparation, I think a course of oral contraceptive or GnRH analog can be given for endometrial preparation. And this is most important. People are favoring when we're doing TCRE, the endometrial resection. When we're doing it, the thicker endometrium is not able to resect, and therefore endometrial preparation was more favored in those cases where they are planned for the resection procedure. Need for concomitant laparoscopy. I think if you are evaluating the case for as an infertility, I think the concomitant diagnostic hystero and laparoscopy are the best method for that. We can't say that yes, DHL is the only thing which is done in the first resort in infertility. No, I don't say that. There must be some indications for, because still there is a minimal invasive surgery and patient is infertile and within 1 year completed, young age. You don't have to do a hysterolaparoscopy for that. There are some indications for hysterolaparoscopy for duration of infertility, age of the patient, treatment received, and some sonographic abnormality of some pathology. Patient complains of dysmenorrhea. You find that there is some problem in that nexa. I think the laparoscopy has to be done in that particular case. So otherwise, HSG is still a method for that. You can't have it's a supplemental procedure. It's a complementary procedure. But believe me, concomitant laparoscopy gives a much better idea of the pelvis interior as well as exterior. I must say that an eye to the pelvis is far superior than 2 fingers in the vagina. And therefore, I feel that eye to the pelvis by laparoscopy from above and hysteroscopy from below, I think that would give a clearer indication of the genital organs and related to the fertility potential for that also. In addition, when we are doing a surgery, concomitant laparoscopy in some of the cases is essential, particularly the synechia. The Asherman syndrome is one of the worst and the most difficult procedure in hysteroscopy. I say always, in laparoscopy, fertility promoting surgery for endometriosis, advanced endometriosis, and the fertility promoting surgery in hysteroscopy for the synechia, Asherman syndrome. These are the two very, very difficult skilled procedure for that also. And there you have to put a scope for that, concomitant laparoscopy. In some cases of septum resection, when we find that yes, you have to do a diagnostic laparoscopy before to say that it's not a bicornate uterus, it is a subseptate uterus, it is essential to do it. Although nowadays the 3D scan can give some of the ideas for that. But initially, when we are doing a TCRS to develop our skill to protect and prevent it, we put a scope laparoscopy to find out whether we have gone too far or not. And that will guide us by the light demonstrated through the hysteroscopy. Then you stop it there for that. But nowadays, with experience, I think it's not a mandatory procedure. Only thing is that you have to be confirmed that it is a septate uterus, not a bicornate uterus for that. Pre-op cervical dilatation. We have a lot of experience prior to the prostaglandins, particularly the misoprostol. We were using in difficult cases where there is a failure or you're doing a hysteroscopic surgery where you anticipate in postmenopausal, in some cases where the difficult dilatation is there, you put this cerviprine gel, intracervical gel we put it. But the main demerits which I have found out, that putting a gel, I think there is a distortion of the viewer vision in the cavity for that, because the gel is inside the uterine cavity. That contents gives a very bad vision unless you have to wash it with the outlet solution for a long time for that. And of course, misoprostol is a gift and boon to the hysteroscopic surgeon as regards the cervical dilatation. In difficult cases, we do it. Now the question comes, many people ask me whether in all hysteroscopy, in diagnostic as well as therapeutic, whether misoprostol can be given or not. I think you can, it's a very important and a tricky question for that. You say that yes, in all cases, it may not be. So in case of multiparous, you go for an evaluation in the abnormal uterine bleeding where the os is open and you can easily dilate it, and you can go for the vaginoscopic examination. It's not necessary. But postmenopausal, previous failure, nulliparity. I think these are the cases. There is no harm in giving a misoprostol prior to the procedure for that also. So pre-op cervical dilatation, particularly the misoprostol, is a boon. And I feel that yes, you can give it 200 milligram to 400 milligram of misoprostol can be given few hours before surgery. The only problem is that the patient will have a little pain and discomfort after the misoprostol insertion. But I feel that yes, if you're going for a surgical, a therapeutic procedure with the dilatation, larger dilatation, I think it's a really beneficial for that. Now coming to the anesthesia part, selection of anesthesia. If you go for office hysteroscopy is all right. You can go for sedation and all that. But I believe that majority of the hysteroscopic surgery is being done with the OT setup, and there the OT setup, the selection of anesthesia for a short procedure like a diagnostic procedure, the total intravenous, I think pentothal or propofol is almost a procedure of choice for that. You can add to the LMA procedure for that. But as far as the major procedure or a therapy hysteroscopic surgery, particularly if you are going for a myoma resection or for a bigger surgery where it takes a little longer time, and we have seen over the period of time that as regional anesthesia is much better than the general anesthesia. When we are using normally earlier long back, we're using the glycine as a medium where you have to use them unipolar. Nowadays the bipolar resectoscope has come out where you're using the saline, and for that I think the toxicity, best toxicity is ammonia toxicity and hyponatremia. And therefore, the cerebral symptoms can be better detected by the patient herself, and rather than before the fluid balance, you can find that this is the cutoff limit of the fluid balance of about 500 ml or 750 ml or 1000 ml. Before that also, the patient can tell that I'm having some discomfort. This is the real advantage of regional anesthesia, where the patient can tell that I am feeling upset, and it can be diagnosed and predicted much earlier to the fluid deficit for that also. And therefore, in major surgery, I will always advocate that yes, this is a procedure when we go, unless you are going for a concomitant laparoscopic procedure. Otherwise, these are the regional anesthesia has a place, particularly for hysteroscopic surgery, and main so particularly for myomectomy for that. Operating setup, I think a good gadget-oriented surgery is important. In technological dependent surgery, I think the team is important for that. Team and tool are most important rather than a single surgeon for that. And therefore, this operating setup is very, very important. You have to check everything before going for a surgery, or the assistant and ask that yes, before going for a proceeding for a surgery, I think this has to be done. And documentation. Nowadays, the endoscopy procedure is easy to document because everything can be recorded. The whole procedure can be recorded and all that. And that record is for your purpose, not for the patient purpose. Earlier, we have documenting and giving to the patient, and there's a lot of legal problem for that. But the documentation has given an opportunity to improve yourself. If you know that these are the problem, or you can replay and find out what is the defect, I should have done this, and correct yourself for that. And apart from the academic interest for publication and all that, documentation is also very, very helpful for that. Now, one of the very important that you understand the tool, I think the instrumentation, very important. What are the instrumentation which is required? I devote little more time for that in the instrumentation because this is important. Telescope, you need a telescope. In laparoscopy also a telescope is required. In hysteroscopy, a telescope is required. And the telescope is different from the laparoscope. There are various types of telescope. In a case of hysteroscopy, it is either a rigid telescope. Majority are using rigid telescope. There could be a flexible telescope. OPD procedure, office hysteroscopy, there are some flexible telescope is there also you can do. But majority of the cases use the rigid telescope. Another is the telescope diameter. The diameter of the telescope, the 4 millimeter telescope is the conventional and usually used by majority of the gynecologists for that also. Now with the advances, with the vision, with the camera, I think the vision is improved with the improvised camera, and there lesser diameter can be used for that also. And 2.9 millimeter telescope can be used, and better visualization, same visualization can be done with that. And this is mandatory for office hysteroscopy for that. Smaller diameter of even 1.9, 2.9, 4 millimeter is there. And remember, either a 0 degree or the 30 degree 4 oblique. This is important. Now, 0 degree can give a panoramic view, and contact hysteroscopy is always a 0 degree, whereas panoramic hysteroscopy, you cannot see the ostia if there are oblique, and therefore 30 degree is essential for that. Some people use 12 degree also, and it can be done, but a little oblique view is necessary to visualize the ostia, and therefore one of the very main concern about the telescope in a case of hysteroscopy is that you have to have a 30 degree 4 oblique, and therefore you rotate on one side, you can see the other side of the ostium very well for that. Otherwise, you cannot see the ostium. And for contact hysteroscopy, you apply the 0 degree and do the job for that also. But majority, we use 4 millimeter. Now, the advantage of lesser diameter of telescope is that you can do it in office procedure and with a small opening without dilatation, also with vaginoscopic examination, you can do it. But the major problem is the maintenance. It's more frequently liable to be fragile, and therefore be cautious about the use of when you're using this smaller diameter of 2.9 and all that. And this is my personal experience also. And because it's at my center, I used to have a training center for that. By this time, I have already broken about 4 smaller telescope and 2 4 millimeter and 4 2.9 millimeter telescope for that also. And this is obvious. This is obvious. I can't blame anybody, but the maintenance is most important for that. And anybody using a lesser than 4 millimeter must be very, very careful about the telescope. Unless he has enough money, you cannot bother about money, then you spend it. Otherwise, this is really a good learning skill for that. Now, the second important aspect is that you need a sheath, because in laparoscopy, by putting a telescope, you can see the interior. But here, a sheath is necessary because you have to distend the medium, distend the uterus by some distancing medium for that. And distending medium is very, very, I will just spend a little time on the distending medium, either normal saline or the high viscous medium or a low viscous with electrolyte or without electrolyte. You can use it, and there are various methods of using that, or you can use a gas medium. Basically, the medium are divided into the gas and liquid, which I will deal with the distending medium. But sheath is 1 millimeter extra than the telescope, because there should be a gap between the telescope and the sheath so that the fluid can come out. And if you're going for a double channel, sheath can be a single channel or a double channel. There are single channel sheath, which is very important for OPD procedure and the small dimensions like 2.9 millimeter scope, where a single channel can be done. Here the fluid will go through one channel, and there is the return fluid will come out of the cervical opening, cervical canal. But the double channel gives a although it is a wider diameter is increased, but the inside the inner channel the fluid goes, and the outer channel fluid comes along with the cervical leak, so that the clarity is there, the wash is there inside. If there is a blood, if there is some dirty material, I think it can be very well washed, and the vision is very good if you are using a double channel sheath for that. So sheath, I will just demonstrate again what are the single channel and the double channel sheath. Lighting, the lighting, same light source as the laparoscopy is done, and xenon is the best. It's a halide, halogen, and xenon. These are the 3 light sources, out of which the xenon light source is the best light source because it gives a white light for that also. And now comes to the distending media. I have already told, to distend the uterine cavity is a hell of that, and there is the distension of the cavity is essential for visualization, and excessive distension is also fatal for the patient. It can cause complications. So optimum distension is important, and there should be a system where the distension should be there, distending system and distending media. The distending media are either a liquid or a gas. Gas carbon dioxide has been used earlier, but we are not using we are very comfortable with the normal saline. I will advise that normal saline is a very good media as a distending media for that. And normal saline it could be normal saline, it could be some of the, if you're doing a surgery, and using the monopolar current, underwater monopolar current, normal saline is conductive and therefore it cannot be used. And therefore, when monopolar underwater cautery was there, monopolar resectoscope was there for surgery, then we use the other methods like the glycine, the sorbitol, and the mannitol. These are the three media which is electrolyte free, and that can be used for that. So the 1.5%, 3%, and 5%, these are the respective thing for the glycine, sorbitol, and mannitol. And this can be used for that. The clarity will be there. And the surgery, you can apply the current through that also. But the main problem over the years we have seen about the toxicity. Many the fatality are due to the fluid, the distending medium rather than the surgery itself. And therefore, the innovators have now, majority of the endohysteroscopic surgeon has shifted from monopolar to bipolar resectoscope. So for diagnostic distending media, saline is all right for that also. And therefore, saline has been used as a distending media for all gynecological diagnostic procedure. And for operative procedure, saline with the bipolar resectoscope is much better. Or if it are using the scissor or with the grasper, I think saline, there is no problem in the saline distending. So saline is the best form for that. You accept that this is the best distending media. Only thing is that if you are a monopolar the resectoscope, you cannot use the saline. You have to shift to the glycine for that. But glycine toxicity is really a concern for that. Now the distending system varies from the gravity to the Medex pump, pressure device, or inflating the saline by some mechanism by increasing the pressure, to the endomat. Endomat is an electronically monitored device for control of the suction and irrigation. That's all. And endomat is nothing. It controls the suction and irrigation and gives a pressure at a certain point for that also. And the pressure, intrauterine pressure, if it is above 70 to 80 millimeter mercury, then only you can see the distension of the cavity. It's visible. Otherwise, before that, below 70 millimeter, you can't see anything for that. And in some cases, where there is a leakage of the fluid through the cervical canal, you are not able to know what was there in the instrument and what is the real in the intrauterine pressure for that. So the visibility is important. There is a lot of global difference between the pressure, high pressure hysteroscopist with the low pressure hysteroscopist. I don't name it, but there is a lot of, I think, debate between this. And I always say, I am not in favor of high pressure or low pressure. I am in favor of optimum pressure. The visualization, if it is not there, the surgery cannot be done in a good way for that. You cannot give a value to the surgery for that. So, basing on the intrauterine pressure, remember that don't go for a prolonged high pressure for a longer time for that also. There are many, it's not only the pressure, the safety is limited to the duration of the surgery also, to the whether you are using the current, that's important. And because we know that 70 millimeter and venous pressure is 4 millimeter. So immediately the pressure will be there and it will be in the circulatory system for that. And believe me, here I can say one thing, that even you are using the normal saline, don't think that is absolutely safe. The thing of hyponatremia or ammonia toxicity like glycine will not happen. But if you are going for a more of fluid, more than 2,500 ml at a time, I think they go for a pulmonary edema, acute pulmonary edema. We have faced that. And therefore, don't say that, yes, only saline is safer. You have to have a fluid deficit for that. Here, the fluid deficit, if you are going for to more than 2 liters, you are cautious about it. But in glycine, more than 500 ml deficit is really you are cautious about it. So documentation of the fluid is very, very important. The pressure, for how long you are giving it, and optimum pressure beyond a certain limit. I think if you are going for a lot of over distension, that will cause a lot of problem, not from the surgery, from the distending media and distending system for that. Accessory instruments, there are some accessory instruments like the scissor, like a grasper, like a morcellator, All these can be an accessory instruments, and you can go for, if you're going for a cannulation, you can go for a cannulation seat for that. And of course, the video imaging is a common thing in all endoscopic procedure for that. Now, a brief account of the demonstration, the video of this. We require two things, mainly the external. If you're going for an operating room, you require a speculum, a helix, and this is the dilator. One specifically, I will say that the dilator for hysteroscopy, you are using it, should be 0.5 apart. It's not 1 apart. So this is the form of dilator which is most suitable for hysteroscopy. And the technique of dilatation is very, very important. That don't dilate and touch the fundus for that. You have to just go beyond the internal os. Then the second, and it depends on which diagnostic needs a dilatation up to 7, 8, and all that. If you're going for a 6, 4 to 5, you have to dilate for 6, 7. And if you're going for a surgical procedure, you have to dilate up to about the 11, 12. Now, this is then the telescope. This is a telescope, has got 3 parts. One is an eyepiece, second is a barrel in the middle, and third is the lens. And this, you remember that it's not a 0 degree. It's a 4 millimeter and 4 millimeter telescope, or 2.59 millimeter telescope, and put into the sheath. This is a single channel sheath. Can you see that this is a single channel with only inlet is there? And 2.9 millimeter telescope, thin, fine telescope is just inserted. Be very careful about it. An alignment should be there in line with the 3 lines are there. In the here, if you are using the single channel, only 2 lines are required. The cable and the line should be in alignment, and only one inlet is there. You can put it the normal saline into it for that. So this is about the single channel telescope for that. And if you are using the 4 millimeter, and this is a double channel, can you see that on the left hand is the inside is the interior or inlet, and the outside is outlet, where there are fenestrated openings in the distal part for that. And you can find that the proximal part closer to the eyepiece is the inlet, and the outer part is the outlet. We always say the fluid, water falls from below and light from above. So you find out which is the inlet and which is the outlet, and this double channel is much more preferable because the clarity of the vision is much more. But you have to dilate a little, and because the diameter is less, and you cannot do it with the office procedure. An anesthesia, short anesthesia is required for this. And you see the bevel edge of about 30 degree, 4 oblique, to visualize both the ostium for that also. And after assembling this, you have to lock it so that now this is the locking and unlocking, in which the same principle lies. The 2 lines of inlet and outlet are in alliance with the cable. I think this is the assembly, and that assembly is very, very important. You must be very, very delicate about this assembly, and just see how the assembly is being done, alignment and all that, and then rotate it anti-clockwise or clockwise to open or detach it, and so that the set is ready for it. And only thing is that you have to put the inlet and outlet channel and connect it to the endomat or a pressure device, and the cable, light cable to the light source, and the conventional camera, the same camera which you can use it for that. Now, second sheath is, this is a purely, the 2 sheaths are diagnostic. This is an operative sheath. This is an operative sheath. I think the caliber is not much as compared to the resectoscope. It is about 5 millimeter up to 6 millimeter. Same 4 millimeter telescope is being introduced into. There are 2 channels into it, and one is the inlet and one is the outlet. Can you see that? And along with that, there is an operative channel for that. So it comes around 6 to 7 millimeter overall diameter, and you can see the assembly. And this is the rubber plug or rubber plug is there, which blocks it, and you can introduce the piston is there, the rubber piston is there, and you can introduce your accessory instruments like this. This is an accessory instrument of the semi-flexible metallic instrument, but semi-flexible. You can introduce it through that rubber sleeve or the clip or the nipple. This is called a rubber nipple, and you can see that how there is a space in between along with the inlet and outlet for that. And you can do some of the minor procedures like a biopsy, you can do it, and the polyp removal, biopsy, many things. And this is a scissor where you can use it and cut the adhesions, or even septum, thin septum, you can cut it, or you can introduce, this is a common thing, hysteroscopic cannulation, proximal tube cannulation, the cannulation catheter. You can see that cannulation catheter, either a Cook's or Indianized the catheter can be used. This catheter contains mainly the two parts outside with the stellate. With the stellate, it can be used, and after removing the stellate, you introduce a Teflon catheter, which goes and negotiate with the under vision to the tube and all that. So this is important. Now the third important is a surgical procedure, hysteroscopic surgery, is the resectoscope. This resectoscope, I have already told, either a bipolar resectoscope or a unipolar resectoscope. It has a working element, and this working element is loaded with either a loop or a Collins, or a ball, whichever. If you are going for an ablation, ball is important. If you are going for a resection of myoma or endometrium, you need a loop, and if you are going for a septum resection, you need a Collins knife for that. So this is the assembly of the working element with the two seats, inlet and outlet, with the two channels, and along with that, the working element, the loop is being used, and the cutting is done by the current. So the bipolar, or nowadays we are using the bipolar, the cable has to be inserted to fit it with that, and that is connected to the electrosurgical unit for that. So this is how, this is a working element, and you see the loop and the Collins knife, and you see the difference between the unipolar. All bipolar resectoscope and bipolar accessories are completely different from unipolar, and therefore you cannot interchange that. And this as a bipolar loop is completely different from unipolar, and this is a bipolar loop. Can you find that this is a the design is such that is along with the loop there is another metal behind it, and this is a Collins knife which can be inserted into the working element. This is how you insert the working element with that, and there is a slot, and you can go, and directly there are two prongs, and the two prongs, the unipolar has got one prong, you have got two prongs which can be inserted and touched to the cable, and therefore after inserting that, then the two different seats, inlet and outlet, and a silicon tip is there to protect it from operating, and current is flowing through that, and that silicon is very, very safety for that. And this is how, this is the cable which has to be connected to that, and there is a slot in the cable in the resectoscope where you fit it, and this is how it is being fitted, and then the wire has to be collected to the electrosurgical unit, to the underwater cautery. And this is a bipolar, brightest example of bipolar. We are using the normal saline, and this set is same as the resectoscope of the urologist. The urological resectoscope and the gynecological hysteroscope, the equipment are all same. When it is kept in the gynecologist office, then it is called a hysteroscope, and when it is in the urologist office, it is a urological resectoscope for that. That is the same difference. Maybe that the price is same, or it depends on the bargaining capacity of the urologist. Has got more of bargaining capacity, they can get a lesser price for that. Now coming to the distancing system, the HAMO is the founder, and HAMO is the leader in formulating this endomat, and this endomat is an electronically devised equipment for suction irrigation. You see in the extreme right, I find a bar from 0 to 0.0 to 0.8, and you can increase or decrease by the marking. And when you do not want a suction, you keep it at a minimum of 0 or 0.1. And if you want more of suction, if there is a clearance of the fluid and vision, you can increase or decrease. The middle one is the millimeter of mercury, and that has to be set at a particular level, or a critical level of around 80 millimeter, or in some cases when there is a more of leakage, you can increase it. If the vision is not there, more of leakage is there, you can increase it up to 150 millimeter mercury. There is no harm for that also. And in the extreme left is the ml, fluid ml per minute, and that is up to about 500 ml per minute, and normally 200 and 300 ml is enough for that. And this is how the connection is there, and you can connect it, and the endomat on, and you can connect it with that. Second important, this endomat costs very, the company people are charging every year, they are increasing the price for that, but it is safe for that. Now, if you do not have an endomat, this could be an alternative, but this is not an ultimate solution for that. Endomat, before endomat also, we are using the Medex pump. We are rolling the pump, Medex pump, a cover over the normal saline, plastic normal saline, and with or without a manometer, and increasing the pressure by the cuff. Now, this pressure, normally, if you compare, much better is this type, without a manometer. Without, earlier we were using the Medex pump, the cheaper Indianized indigenous variety, and spend 30 rupees and get it the endomat and the pressure device for that. This just a tubing connected to the needle, and the needle is above, puncture the needle above the water level, above the saline level, and increase the pressure inside the bottle, so that even if you are using the 500 ml, you can do 3 diagnostic hysteroscopy procedure with 500 ml also. Till the last drop, the pressure is maintained. That is the main advantage of that, in comparison to the Medex, where after 100 or 200 ml, pressure diminishes for that. And this is the electrosurgical device. We should have the monopolar separate, bipolar separate. This because we are using the underwater cautery, and underwater cautery is the cautery which flows inside the water of normal saline, bipolar or unipolar. If you are using, then glycine is a must, because the conduction is a major factor for that. So these are some of the pressure distancing system and the distancing media which can be used for that, and that is very, very important for that. Now this is after assembly, I'm just showing it, that the tube inlet and outlet, just difference, water from below and light from above, and the nearer to the cable is the inlet. But at times there is a practical difficulties of difference, where is the inlet and where, and that's why I will recommend you that the inlet I put another tubing. So inlet tubing is different than the outlet tubing. So it's a really the inlet tubing, you can know that inlet is a larger bore, and you can do that, and because you can fit it the two things in a different manner to dissimilar things, so that inlet and outlet can be diagnosed for that. So this is how you combine and procedure start with that. Now this is a flexible hysterofibroscopy, where in some cases in OPD procedure this can be used for that, and particularly when the dilatation is a real problem, the flexible hysterofibroscopy is being used, but it's not very commonly used by gynecologists for that. And this is a set of the cart. You can keep all the endoscopic gadgets. You have to require a vision light source. You have to have a good camera with the monitor and the electrosurgical unit. The position is again like a lithotomy position. The position is really important, as gynecologists sit behind, and good position is there to safety of the patient, not to have the neurological damage, because of course the hysteroscopy procedure is a very short procedure. Normally in comparison to the laparoscopy, it doesn't happen, but this is a normal position for the hysteroscopic procedures. Now coming to the hysteroscopic procedures, I will just share some of my surgical videos where you can know the different procedures. I will just start next. Now this is a case, a diagnostic hysteroscopy, normal cavity. This is a case of normal cavity. You put a scope, and this is a normal saline, and with a 30-degree, you rotate on the left side, see the right ostium. Rotate on the right side, see the left ostium, and the surface you can see very clearly. And then while withdrawing, you can see the endocervical canal. It hardly takes 30 seconds for completion of the procedure, and get a lot of information for that. This is a case where you find what you find here. I showed here to find, and I asked my students, what is this? They say that is a tuberculosis. It's not a tuberculosis, mind it. It's a gland opening. These are all normal hysteroscopic finding in a cavity in a surface, and because of the high resolution camera of the HD, we see that the gland openings, these are all gland openings. I have seen many cases where after this they give an anti-tubercular. Be cautious, these are all gland opening. It's not a tuberculosis. And this is again a normal cavity which you find in hysteroscopy for that. But all ostia, both the anterior, posterior, and lateral wall, you have to see for that. And this is a combined procedure of diagnostic hysteroscopy and laparoscopy, which you do in an infertility, and you find a laparoscopy also absolutely normal finding for that. And you see the uterus, you see the ovary, you see the tubes, you see the omentum and other thing. No evidence of tuberculosis is there, absolutely normal for that. So, and don't confuse with this tuberculosis with that, and have a good clear vision. And therefore, this is a procedure of diagnostic hysterolaparoscopy as a minimal invasive procedure for infertility evaluation for that. And now, after that, you put a dye and find the chromoperturbation, and either side, they see that the dye is coming from both sides, absolutely normal. And now, after the seeing the dye, the gynecologist become very happy that yes, now my patient will conceive, and pray God and all that and that. But the major thing is that a combined procedure avoids a lot of other difficulties, and therefore gives a more information than what it does the previous thing we do it. Now this is a thing which I want to show. Now this is again a case where you find that this is a case of endometriosis. Can you diagnose adenomyosis? Can you diagnose, can you think, and can you suspect endometriosis? Yes. One of the pointer is that both the ostia are pointing backwards. If you find that it is not lateral and both the ostia are pointing backwards, that means it is a fixed retroversion. And this is a case where you find that there is some adhesions, and therefore you suspect that this could be endometriosis. Confirmation by laparoscopy, but hysteroscopically you can suspect that. Another hysteroscopic pointer in a case of adenomyosis is that you find a longitudinal ridges. This is our observation over years, that there are longitudinal ridges in the fundus. You can find in the fundus, you can find the longitudinal ridges. When there is a longitudinal ridges and both the ostia are backwards and backwards pointing, and these are the cases pelvic endometriosis and with adenomyosis. So the longitudinal ridges is in favor of adenomyosis, pointing backwards is in favor of pelvic endometriosis for that. Now you find another irregular surface, and you find the surface. You look at the surface. Now the ostium is all right. You're going through the cavity, and now you can rotate it, and both the ostia can be visualized. You can see the water bubble, and just finding that the bubble is going through the ostia is not sufficient to say that the tubes are patent. It could be one other possibility, but it is not a confirmed procedure for that. But you see that the both ostia is there, and see the surface. Most important is the surface. Can you see the surface? It's irregular, and sonography reveals there is a thickened endometrium, hyperplastic, and these are all like a paddy field in summer. In hot summer, the paddy field. And these are classical and positive correlation with either excessive progesterone use or hyperplastic endometrium. Could be simple hyperplasia, could be complex hyperplasia with or without ATPF for that. And looking at the cavity, one can really correlate and find out that this is certainly not normal, because we have seen the earlier view that it's absolutely smooth, and this smoothness of the surface is not there with that, and therefore it's a most probably hyperplastic endometrium, and a positive correlation is there for that. Now this is a case of postmenopausal bleeding, and remember, in all abnormal uterine bleeding, in postmenopausal in particular, gone are the days of the biopsy from different quadrants and all that, fractional curettes. We were students were reading. Now put a telescope, put a hysteroscope, and find out the cavity. You can see the suspicious areas and some of the abnormal polypoid growth, and you take a biopsy, directed biopsy, and find out the level, whether it is above the cervix, cervical canal, or below it, it is enclosed. You can know it and stage the disease for that also. Now this is another case where we find that yes, absolutely the visualization of the cavity is not very clear, and there are whitish flecks, and there are whitish flecks there on the endometrium, and along with that you find that there is an adhesion, there is a synovial band, you can find it. This is particularly suspicious of tuberculosis, and these are the cases you do a histopathology to confirm it for tuberculosis. But hysteroscopy have a very good correlation with the tuberculosis. If you find this type of epithelial endometrium or surface irregularity with synechia, I think these are some of the, along with that, there are tubercles where you find. You can differentiate this from the gland opening for that. And this is classically the tubercular endometriosis, which is correlated with that. This is another case, a very young age, middle-aged, of course, about 30 to 33, paras lady, but the bleeding continues irrespective of the medical management and all that. I found that, yes, putting a scope, the ultrasound is normal. Diagnostic hysteroscope revealed the vascular endometrium. Can you see the vascularity of the endometrium? And this vascular endometrium could be a vascular cause for that. And therefore, this could be one of the causes, a vascular cause of abnormal uterine bleeding, which can be undetermined. And therefore, the palm coin N could be there, either a AV malformation or undetermined cause for that. Vascular cause could be there, attributed to the pathology for that. So if you devote more time and see with the high resolution camera, everything can be depicted very well for that. Now, this is how we do a vaginoscopic approach. We say that, yes, office procedure, we do that, and we are not putting any speculum, neither catching the tenaculum. You just do vaginoscopic examination, put a distance and media with a 2.9 millimeter and close the vulva. Ask your assistant to close the vulva a little, so that little distance. And the fluid will guide you the point where there is a cervical opening, the ectocervix, the endocervical internal os. Then you enter into the cavity. And this is a very, very important thing, office hysteroscopy, and you can do a good job with that. And this is a vaginoscopic approach. You don't have to catch the fundus, catch the cervix for that also, and see the ostia on either side and its middle. And this is very much preferable, and it can prevent the perforation. And this is an alternative if you are going for a dilator, is avoided, and therefore the perforation chance is much less in this particular case, unless you perforate with the telescope for that. This is again a cavity which is an abnormal cavity. It is a tubular cavity with only one ostium which is being seen. And this is with one ostium. This is a case of, you can see all around and find out that this is a uniconvate uterus. And you can confirm it by doing a laparoscopy, concomitant laparoscopy, and confirm the Mullerian abnormality. And this is just an evaluation for a case of a recurrent pregnancy loss. And the obvious cause is a tubular cavity or the uniconvate uterus for that. Now, this is a case where you put a telescope, where you put a hysteroscopic, and hysteroscopic view came as a solitary polyp. With the conventional hysteroscopy with a small polyp, one may not be able to diagnose that. That can confuse with hyperplasia. But I think only thing is that saline infusions or contrast sonography can detect, can suspect this. But this is a direct visualization, which is 100% correct for that. This is a case again, a postmenopausal lady. Again, you can see the surface is all right everywhere, is normal, and there is a polyp arising from the left lateral posterolateral aspect and near the cornu, near the ostium, below the ostium, and the histopathology can confirm that this is the case. But this polyp needs an evaluation. You do a polypectomy and send it and for histopathologic examination for that. And here is again a postmenopausal women presenting with this suspicious of endometrial. Good resolution sonography can give an evidence of the endometrial polyp for that. And you find the whole cavity is filled with the polyp, and it's a vascular polyp, and histopathology can be confirmatory, but you remove the polyp. If the polyp, after removal, hysteroscopic removal, polyp, the whole cavity is normal, and if the pathology came, histopathology came as a benign, you can leave it as such, no issue, just a follow-up for that, and patient will be absolutely all right for that. And majority of the so-called postmenopausal bleeding are either a functional abnormal uterine bleeding and or this a case of polyp. These are the cases, and very few cases when we hysteroscopically find that it's a suspicious of malignancy, then we go for the subsequent management. Otherwise, just removal of that polyp is enough for that. This again, varieties of polyp you can find, varieties and patients and different. This is again a polyp. It is a really a petal shaped polyp. It's like a flower. It's like a flower. The solitary polyp. Remember the polyp, whether you find a solitary polyp or a polypoidal endometrium, these are completely different. A solitary polyp needs a treatment because this gives rise to either pregnancy loss or infertility for them. Polypoidal endometrium, when you find it is a hormonal disturbance and hyperestrogenic state, and these are the cases which requires a medical management for that also. And this polyp must be very well tackled with the hysteroscopy procedure for that. This is another polyp. You find that everything is there, but the ostium, near the ostium, there is a polyp. And in unexplained infertility, this could be one of the cause. But unlikely this polyp could be preventing this sperm entering. I have a doubt for that. But still, in unexplained infertility, I have some experience that you just remove it, catch it up with the forceps, and just remove it. You can twist it with the hysteroscopic forceps and then remove it, and that becomes a. So this is one example where I can show you that ostial polyp can be a cause of infertility for that. And bilateral, this is good. It cannot be a mechanical, but somehow it could be contributed for that also. Now you see, this is a case where, in contrast to the solitary polyp, this is everywhere. There is a irregular surface, polypoid endometrium. All these are majority of the cases. Can you see this? And these are all abnormal uterine bleeding supplemented with the long-term progestrogens, and these excess progesterone activity can give rise to. But a biopsy is absolutely necessary when you look at the hysteroscopic view. That biopsy is absolutely necessary for that. But believe me, if you compare with the blind dilatation curettage and look at this in this generation, and when we are practicing science with the rationality, I think this is nothing. This is very, very important that scientifical, you get satisfied that these are the cases. When you do hysteroscopy supplemented with the blind DNC, you are satisfied that you are doing a good job for that. Now, coming to the operative procedure, this is a solitary polyp, and the patient presented with 2 previous losses along with menorrhagic cycle, and the sonography reveals that there is a thickened endometrium of about 18 millimeter. But on putting a hysteroscopy, you find that. And here the polyp is removed. Push the roller, I think the loop, the cutting loop, and you can find the difference between this and myoma is completely different. You see the texture of this after cutting it. It's absolutely, looking at that texture, it's a soft, and you can see this is a polyp. It's not a myoma. Myoma resection, you can find clearly the muscular tissue and fibroid. And this is typically a case of solitary polyp which needs treatment for that also, either infertility or a pregnancy loss or even abnormal uterine bleeding. Patient is fertile, patient is having babies, but abnormal uterine bleeding and young age 30, 35, and don't do a hysterectomy here, just polypectomy is enough for that also. And believe me, these are all bipolar. So within a short time, try to finish it as quickly as possible, maintain the fluid balance, and all the myoma or a polyp is very easy according to the location. When you find that absolutely the base is clear, and on completion of the procedure, you can be certain that I have done a good job for that. And in posterior or a lateral situation, it's much easier than the anterior or fundal. Believe me, if it is a fundal or anterior, it's a difficult than the posterior. It's again a lateral wall arising from the right lateral wall. Again, a vascular polyp. You just either you can use the same thing by the loop. And remember, when there's a vascular polyp, you just coagulate at the base and then resect it, so that it will much better for that. Or you can do by seizure also. You can cut it by seizure, but remember that there could be bleeding. And or you can grasp it and just rotate it, twist it, and with the your forceps, your the hysteroscopic forceps, you can hold the pedicle at the base and just twist it and it will become out for that. And this doesn't require any electrosurgical equipment for that also. Like this, you can hold the base and just twist it, and by twisting it can, just like a myomatous polyp, cervical polyp, it can twist it and it will be out for that. This is another method. Apart from not using the electrosurgical equipment, we can remove the polyp for that. Even with the your own telescope and the diagnostic sheath also, you can just push it and clear the procedure. Now it's completely out, and this is another method by which a small polyp can be removed for that. Bigger polyp is very difficult. It's you have to use it for that. Now this is again a bigger polyp and a vascular polyp. You have to just coagulate that on the base. This is a vessel which is there, coagulate that from the base so that the vessels can be coagulated, the bleeding will be less, and then you can find that yes, do the job complete, resection of the polyp with the loop and applying the electrosurgical equipment. And this is how the resectoscope, the bipolar resectoscope, I have already shown you that resectoscope. I'm using it. It's complete, almost filling 2/3 of the cavity. When you distend it, you can be found. But once it is you cannot remove it by just removing at the base, because piece by piece, if you can remove it, the removal is much better. The completely you can see, and the whole tissue can be sent for histopathological examination also. So this is how a polyp, solitary polyp, you can resect it by the hysteroscopy for that. Now this is another case again. You go and see what is there inside, a case of abnormal uterine bleeding, and young age 32, 33 years, and you can see again this is a polyp, and see the texture that it is not a case of myoma. The tissue texture will reveal that it's a case of endometrial polyp and a solitary polyp, and these are maybe a cause of infertility, maybe a cause of reproductive pregnancy, recurrent pregnancy loss, or commonly abnormal uterine bleeding. And if you keep the uterus, you don't have to remove the uterus in this particular individual, and do a good job by just 10-15 minutes procedure by the bipolar resectoscope. You can complete the procedure for that. You can see how under vision you can do complete resection, and up till base you can go it for that, and finish the procedure and discharge the patient next day, or in the evening you can discharge within hours. Patient will be absolutely normal, and that is the procedure. Then this is the base for which you can go for that. But remember, this when you are using the polyp or myoma, the procedure is you go beyond that and just have a passive, not have an active. So there's a difference that you movement of the telescope, movement of the working element should be from above below, and you can see that from above below this is the remnant part with the there. But initially I've gone from below because I've coagulated the vessels in the pedicle, in the base, and now we find that this is the complete procedure. Whole of the polyp is removed. You can see the base and clear that. If there's a bleeding, you can apply the coagulation, and active bleeders can be easily. But this is a cutting current which say, and coagulation current. If there is an active bleeding, you can do that and send the specimen for biopsy for that. Now this is another case. You can see that these are the cases where, again, another thing where you find that yes, there is a polyp. You can see that there is a polyp, endometrial polyp, and you can see that there is a septum also. And now I find that after going to the septum and one ostia, closer to the ostia, there is another submucous myoma. So there is a 4-in-1. This is a 4-in-1 in case where the very unlucky patient and a lucky surgeon, that one case you have 4-in-1, one septum, one polyp, and one the myoma, and along with that the tubal block is there, and you do the cannulation for that. Now next is about the septum. One of the most rewarding surgery in hysteroscopy is the septum, but you have to select the septum. Indication of the septum is not primarily infertility but a recurrent pregnancy loss. But in some cases, when you find the septum, in a case of infertility also, you need to operate, because in cases when there is a long septum, or the patient is going for some assisted reproductive technology, or in unexplained, you have done all investigations, you have tried a lot, and then think that most probably the implantation is on the fibrous septum. That is the only indication for doing a septoplasty for that. So pre-op evaluation, I've already told you, assess and indication must be very genuine. The techniques is that either with the Caesar or with the laser or with the Versa point or with the resectoscope. So resectoscope is commonly being used, and I personally use the resectoscope in majority of these. Unless it is a very thin septum, we use the Caesar. Otherwise, Caesar, a thick septum, is very difficult to cut it. Only you can cut up till the endometrium, not beyond that further. And there will be bleeding. And this electrosurgical device, using the bipolar device, you can do a good job. The bleeding is less, and you can control it with exactly 90-degree, and the same line you can do that. And the only thing is that the completeness. The common question raised, that when can you know that it's complete? I think this is a case where there are multiple things has to be done for that. So once you see both the ostia in the same plane, I think it's one point in favor of that. And second point is that when the muscular pinkish surface comes, and that is the end point. When the bleeders are more, that is the end point for that. And you can guess it before doing an MRI. You can do a 3D scan and find out the muscle. Otherwise, you overcut it. So always you undercut in a big septum, you undercut, and rather than the overcut and doing a perforation for that also. In that, initially we are doing a laparoscopic evaluation for that. And remember, a laparoscopy is must to find out it's a broad fundus, but at times we find there is an indentation in the fundus. If there is an indentation in the fundus, in the central part, don't cut it much. In the lateral part, you do it. But if the dome is there from the laparoscopy, dome of fundus is there, you can go ahead and cut it. And remember that the optimum cut has to be done for pregnancy preservation, not affecting the uterine muscle for weakness, for subsequent rupture for that also. So these are some of the steps has to be taken for septoplasty when you are using the current for that. And complications, post-op care, I will just narrate when I will deal with the complications for that. Is again septum. This is another septum giving example of a diagnostic. You can see the laparoscopic view. They completely, this signifies the union between the two halves of the Mullerian system. The line is being evident for that. And inside you can find that there's just an arcuate. It's just an arcuate, and it is less than 1 centimeter by the 3D scan, and therefore don't need a surgery for that. It doesn't require any surgery for that. And this is another case where you find a cavity, and this cavity, when you find that the right ostium is at a deeper level than the left ostium, it's not at the same place. Can you see the left ostium and the right ostium? There is a septum, but asymmetric septum. So these are the cases of asymmetric septum where there is a pregnancy loss, and you have to be very careful on the septal resection for that. So you have to resect on the right side more than the left side so that you balance it. So this is some individual difference, asymmetric septum for that. This is again a case of recurrent pregnancy loss, and you find a small subseptum, and it is a 1/4 and 1/4 of the cavity. This subseptum, suppose it would have been an infertility surgery, is not indicated for that. But because there is a previous history of pregnancy loss, or the patient is going for IVF, even 1/4 septum must be excised for that. And remember about the same point, what is the limit of this? Looking at both the ostia, the vascularity, the color, pink or white, that will determine the endpoint for septum resection for that. This again, there are various varieties. Human beings are such that individual, there are some difference in that. And here you find the ostium is there, one ostium, the other ostium is there on the other side, and in between there is a thin septum, and in between there is a thin septum. The ostium is there, and so this can be really cut with the Caesar also, or with the resectoscope. Just make it, and it's very easy to do this septoplasty for that. And when there is a thicker septum, there is a need for removal of the muscle tissue along with that. So after doing a septoplasty, you do use the loop for removal of the redundant portion of the tissue. Otherwise, majority of the fibrous tissue will retract, and in majority of the cases, it's not necessary to do the resection for that. Otherwise, this is a procedure which is very, very important. Now, you find in this particular case, initially the most distal part is very thin, but as you go more towards the fundus, it is thicker and thicker for that. So it's like a really a bevel edge, and therefore the distal part is more thicker than the proximal part, and thicker part is better managed by current rather than by the seizure for that. This is my personal experience for that. This is again a case where a hysteroscopy is being done, and you can find a long septum starting from the cervix. It's right from the mid part of the cervix, just beyond the external os. You find that there is a laparoscopy, there is a broad fundus. You see for the patency and started. The difficulty of this hysteroscopy, in the beginning there is a difficulty of negotiating, and once you find that these are it's at the lowest level, you just go it, and once you find it out, and it becomes very easy, within minutes you can fill the job for that. But long septum, particularly in the cervix, gives a really problem in the initial phase of introduction of your resectoscope and the channel, and the procedure is little tricky, and therefore you just after the initial difficulty, you can complete the procedure with that, and anybody within minutes. There's a very good hand, eye, and foot control. That's important in hysteroscopic surgery. A good eye-hand coordination with the foot is essential, and for the good piece of job and good surgery for that. So this the same thing happens. The limit of surgery you decide, and better you do it undercut rather than overcut. You can do it in a check hysteroscopy and then complete the procedure in between. Then creating problem of thinning the muscle part in the fundus in the central part, giving rise to the weakness in the subsequent pregnancy for that. So this is one aspect where you must take, that you don't perforate it and keep the muscle optimum for the sustenance of the pregnancy, in order to not to have a silent rupture during the time of pregnancy for that. So on either side in the midline, you just cut it. You can control it if you are using electrosurgical device. You cannot control it by other methods for that, and therefore it is much more better. And now the cavity, a good cavity is formed for the pregnancy to continue for that. This is another case where the patient, a young patient, unmarried, the adolescent girl came to me, and she was having terrible dysmenorrhea, not relieved with any pain. On sonography, we find anechoic area in the uterus itself. Anechoic area in the uterus could be either adenomyosis giving rise to this, or it could be a non-communicating horn. On laparoscopy, I find that there is no non-communicating horn, but on the right side, we find that there is a bulge. There is a bulge here, and correlating with the sonography finding of an anechoic collection, or thinking that it could be hematometra, partial hematometra on the other side, right side, with the same current. This is the procedure where we get bipolar Collins knife and go very gently, because see the prominence of the right projection to the cavity, and once you go deep inside with the control, and you see still we are not able to find out anything for that, and I feel that this is a good job. We can find it out by a hysteroscopic procedure. It's a very atypical case of the septum not connected to the original cavity, and here we can see the two ostium, the one ostium, but the other ostium is not being found, and it is not connected with that. So slowly we are going to find out again entrance into that, and now with the laterally in the same plane, we have to go and find out whether there is something or the connection is there or not. Now we could find that yes, there is a altered blood which is coming, and that is the point where the sonographic say that yes, it's a collection in that, and old blood is coming from that, and This is a non-communicating septum to the other healthy horn or a communicating horn. And this is how hysteroscopy is a very, very rewarding surgery for this particular case for that. And believe me, after that, the patient is completely relieved of pain, and then subsequently married and have an uneventful pregnancy, and the mother of 2 children by now for that. So this is how the hysteroscopy is a boon for fertility, not only fertility augmentation, but for the treatment of this type of atypical cases for that. And these are the cases where the other horns and the original communicating horns are just made same, and you can see the osteum now. The other osteum can be very well seen after the procedure is over. And this is another type of septum, a typical septum, where they manifested with severe dysmenorrhea with the hematometra, the partial acquired hematometra on the other side, the congenital hematometra on the other side, 1/2 for that. So this will give a suspicion of that. A couple of cases like this we have found out, and this I find that this atypical case I must share with you, and so that it can be a learning for the junior, the next gen people for that. So always you don't find classical cases, but see and apply your brain and apply your technology, and that can help you in really getting a good service for that and a good piece of surgery for that. Now, coming to the intrauterine adhesions, I have told that in laparoscopy, conservative surgery, fertility promoting surgery for endometriosis is one of the pinnacle. And here in hysteroscopy, the pinnacle and most difficult is Asserman syndrome, intrauterine adhesion, and more so the degree of adhesions is related to the prognosis. The goal and means what you do it. Goal of this intrauterine adhesion, restore uterine architecture to normal. How you can make it? It means lysis under direct vision. You can do it only by hysteroscopy, lysis under direct vision. Prevent readherence, you can use intrauterine splint or some other procedure. Promote endometrial overgrowth, you give some hormones high dose, and verify cavity normalcy. Follow up histogram or hysteroscopy after a couple of months for that. So these are goals of that. And this is the classification of intrauterine adhesion by hysteroscopic findings. Severe adhesion, more than 3/4 of the uterine cavity is involved. Agglutination of walls or thick bands, osteal areas and upper cavity occluded. Moderate is 1/4 to 3/4 of the uterine cavity involved. No agglutination of walls, adhesions only, osteal areas and upper fundus only partially occluded. And minimal, less than 1/4 of the uterine cavity involved. Thin or flimsy adhesions, osteal areas and upper fundus minimally involved or clear. Believe me, in a case of tuberculosis, we find a complete synechia for that, and that becomes little prognosis is worse for that. But in a case of minimal to moderate synechia adhesions, I think you can restore the uterine cavity and promote the fertility as well as the menstrual function for that. So this is how with the forceps you can just lyse it. Even this can be lysed with the telescope and the seat for that. If you're a complete the band of adhesions, you can catch hold of that and just twist it, and you can create a good cavity for that without the electrosurgical device, because electrosurgical device has a risk of that you do not know. That's why we always do under laparoscopic guidance, and severe the adhesions, more is the indication of doing the laparoscopic guidance for that. And this is how we complete the procedure of Asserman. The good cavity is being formed here after gradually in all areas you find, and just twist it, the adhesions, and then you can add it with the estrogen progesterone combination or a Primarin for a couple of months, and then do the job for that. Many people use the intrauterine device, copper T or Lippes loop. Also, Lippes loop is not available. Wider the more torch area is much better than the copper T. So wider the area of contact, better is for the synechia prevention for that. Now, this is a case. Have a look on that. This is a case where you put it, the scope inside, and go inside and find that yes, there is a complete uterine synechia. I got a couple of cases referred from a hysteroscopist. That is a complete synechia for gynecolysis. I put a scope on that, and again we find that there is another hole, black hole in the top. So You just turn the telescope upwards and find this is a synechia. This is so-called synechia where you just is misleading and you go and find a normal cavity for that. So this is a false passage which gives erroneous idea of synechia. So beware, and this is a trick I'm giving you while doing a hysteroscopy. Look for that. If there is a synechia, whether it's in the correct plane, whether it's a false passage or it's a real cavity for that. So this is a lesson for all gynecologists that this happens for that. Now this is again a synechiolysis, a band of adhesions. Fortunately, these are synechia bands, synechial bands, and it's a flimsy bands for that. And with a telescope, with the seed, or with your Caesar, or with your grasper, the blunt, the forceps, hysteroscopic forceps, you can just twist it and just break the synechia, and completely you find a good cavity for that, for fertility as well as for the recurrent pregnancy loss for that. So I have already told that yes, minimal to moderate synechia, better is the prognosis, and severe synechia, whatever you do, I think I'm really vexed with the severe synechia. Even you try for all methods, it's not very useful. Maybe that in repeated seating, I've done a couple of cases. I remember in repeated seating, the patient was in secondary amenorrhea, has menstruated, and about 20% do conceive after the procedure. That will depend on the grades of synechia for that. But a good job you can do it with the hysteroscopy, and for the pregnancy outcome will be very good for that. Again, this is another case of the synechia, which mimics as if it's a septum, but it's a septum, it's on the one side, and you find a band, it's cut, and it's a septum. It's not a septum, it's a synechial band. And this synechial band can give rise to the recurrent pregnancy loss. And this band occurs many times after an induced abortion. Induced abortion, you do a curettage, many people do a curettage, and infection giving rise to the band. And if they had an incomplete synechia like this, and prognosis is very good for that, and it can be done with very reasonable skill. Now, next is about the myoma, hysteroscopic resection of the myoma, intrauterine myoma, that is mainly restricted to the submucous variety. If you classify the FIGO varieties from 0 to 8, I think 0, 1, and 2 can be best tackled with the hysteroscope for that. And expert endoscopy hysteroscopists can do up till about 3, but 0, 1, and 2 can be better dealt with this. And this is a case where the vascular pedicle is coagulated at the base and then going for a resection. You can find the difference between this tissue texture and the polyp. From looking at that, you can say that it's a myoma, it's not a polyp. And after resection, you can find the muscle. You can find the muscle wall, uterine muscular thing, a myoma. If you cut a GFA myoma, the texture is same as that. So before going for that, analysis of symptomatology is made. What for she has come? Whether she has come for menorrhagic cycle, these are the cases where adolescent girl also, they present tons and tons of hormones, they are not responding. You do a sonography, they will give a small either a myoma or a polyp or a hyperplastic endometrium for that. And non-responding to that, you put a scope and find that there is a small myoma, submucous myoma, and that's the best rewarding surgery for this unmarried girl for that. And same thing happened with the space occupying lesion giving rise to recurrent pregnancy loss, and also infertility and abnormal uterine bleeding. All these where they want to keep the pregnancy. I think you go with that. The only problem is that the timing. Don't go and you do it with the bipolar resectoscope. Even with the bipolar, you are using the saline. They see that the fluid balance has to be maintained. Regional anesthesia is much better, as I've already told you. And as far as possible, quickly you do it. The procedure, shorter the period of surgery, better is the outcome, because the absorption will be less. But still have a vigilance on that. You can give a diuretic if there is any problem, and majority of the cases that can be averted. The pulmonary edema can be averted, prevented, or treated by giving an excessive diuretic therapy for that. So one of the thing in myoma resection is that this is if there is a grade 0, It's very easy for that. But in grade 1 and grade 2, the base has to be there, and you have to remove the myoma completely from the base, and from the muscle tissue, from the capsule. You can delineate the capsule and all that with high resolution camera like Chroma and Clara of HD. I think we can clearly delineate the which is the capsule for that, and you can remove it in a cupwise fashion, go deeper, and find out that at the same level you can find out. Otherwise, in a grade 0, you just at the same level you remove it, everything is okay for that. But in grade 2 and grade 3, once you cut, the more of the tissues will pop out for that, and it's easier that you do the procedure and see the amount of tissue which can be removed and send it for histopathological examination for that. This again a case of submucous myoma, and you just evaluate both the ostia, the surface, and now both the ostia and surface is thin, and this is a myoma. Again, laparoscopy. This is a case of infertility and with menorrhagic cycle, and therefore laparoscopy, concomitant laparoscopy is done. Otherwise, for this myoma resection, laparoscopy is not mandatory for that, and these are the cases where you can completely do the job of evaluating the infertility as well as the myoma resection for better outcome in terms of elevating the menorrhagic cycle, or removing the space occupying lesion for enhancing the fertility for that. Now, the same thing with the loop. Loop is the best instrument for that, and I've already told that this myoma is little difficult because it's anterior. I told that yes, previously we see the posterior myoma is anterior and lateral. Lateral is little better and posterior is little better, but more anterior is difficult for that. It is therefore you rotate in all directions to find out for that. But anterior becomes very difficult. Fundal becomes very difficult because orientation of the loop and resection becomes a major part and difficulty for that. So these are the method in which we do it, and any bleeding, active bleeders, we just, this is a cutting current, we apply the coagulation current for that. And you can find the difference between that, which is the capsule. You can find that after resection, you can locate which is the capsule. Now this is the capsule. Can you find it out that this is the capsule where it is lifted, and that is the capsule. That is the point where you go little more deeper inside and just lift it with the loop so that the whole myoma can be lifted out for that. And at the end of the procedure, you can find a gutter and there are a well inside, so that the myoma of grade 1 and grade 2 can be retrieved for that. You can find out that the whole capsule is being. So this is the technique. By the resolution of the camera, you can do a good job, and you can clearly differentiate which is the myomatous tissue and which is the muscle and which is the cleavage for that also. And this is how, it's not that beveling it and making it at the same level as uterine cavity will do the job. That's only for grade 0. Otherwise, in grade 1 and grade 2, it is not possible for that. Is again a submucous myoma. You can find that yes, this is a case where you go above, and this is easier because it's a posterior fibroid. It's easier to, posterior fibroid is little easier. Only thing is that the anterior wall and the cervical fibroid, that creates a lot of problem for that. And the same procedure we find it out. This is a case where you find it's in the endocervical canal, but the upper end can be very well located for that, so that you can reach it at the higher end and start from the higher end with the loop, and from above downwards you just dissect it at one go from above downwards, so that the whole of the chunk can be removed for that also. And believe me, this rapidly you can do it with the vision, and the same capsule, they can find that still there are some myomatous tissue which is there, and identification of the level where you see the capsule and the clear muscle in between. You can find that this is the myomatous tissue and the muscle. You can clearly find the difference in that, and by resection with the help of the good vision of the camera, Clara Lara and Chroma, Lara and Chroma can give an idea as to the differentiation of the tissues for that, so that you don't leave part of the myoma inside for that. And from this resection, you can see that how beautifully you can see the completeness of the procedure, and it takes little more time and a little skill in surgery, but you can do the job. Any average gynecologist can do the job for that, because you have to produce here, it is deep inside, it's like a well, so that you deliver that. Now, this is a case where I was telling that it's an anterior myoma, anterior wall submucous myoma. And here the negotiation of the instrument can be reversed with that. You just change it and reverse the resectoscope as compared to the posterior, and remove that. So this is a little difficult to handle, but it can be done with the same thing. Only thing is that the orientation of the resectoscope should be just different from those in the posterior myoma for that. That is the only thing. And the myoma in the fundus, again, there is a space, and from the left to right or right to left, you can just go, so that you protect the fundus, don't have a injury or perforation in the fundus. At the same time, remove the myomatous tissue in complete go for that, in one sitting for that. In cases where you find multiple myoma, submucous myoma in 3 or 4 myomas, don't do it in same sitting. You have to do particularly opposing surface, if anterior and posterior there, because there is a risk of synechia, you have to do in a second sitting, or you do a check hysteroscopy and find out and break the synechia for that. That's the only thing. And in a bigger size myoma, up till 5 centimeter in one setting, you can go it. But beyond that, in phased manner, you can do it. Do in two sitting, there is not a problem for that. You just enucleate it, and then after 1 month or 1.5 months, you can again subsequently do it, so that in phased manner you can do the procedure for completeness of the cases. Now, this is a case where you find that the cavity, we have done that. This is the cavity, and the sonography says that it's a myoma uterus, but where is the myoma? Now we can find the myoma is in the cervical region. Now, endocervical canal, there is a bulge in that endocervical canal, and the myoma is originating from the posterior wall of the endocervical canal, and the big myoma completely filling the cavity. So these are the difficult cases where the same procedure, the cavity is absolutely normal, both ostia can be very well seen, and you start from above at the boundary, go above the myoma at the lower corpus level, you just find out and then enucleate the myomal tissue. But these are the two difficulties: situation of the myoma, location of the myoma, number of the myoma, and of course the size of the myoma are all determining factors. For surgery, you have to decide and give a good decision and dissection for that, so that you can do a good job in a case of myoma resection for that. Now, this is a case where the morcellator, in comparison to the electrosurgical device, this is a saver system or a morcellator, to and fro movement with the mechanical, just normal saline, and mechanical to and fro movement is the submucous myoma, which you touch it and rotate it on either side, and it could be reduced to small particles, and you aspirate it. Suction is there. You aspirate the gravels to small particles, and all the procedure is out. The only thing is that it could be for a small or a medium-sized submucous myoma can be better. Large myoma, it takes a longer time. It's difficult. Otherwise, the advantage is that you don't have to require an electrosurgical device, and with the normal thing, you morcellate and gravel it to a small particle like sand, and then give a suction for that. And the another problem is about the histopathologic thing and all that. You have to bring all the return liquid and filter it and then send it. But the difficulty in biopsy, histopathological thing and all that. But this is a system where saver system or a morcellator, myoma morcellator, which can be done. And this is one method which I've sold in, other than the electrosurgical thing like resectoscope. You don't have to put a resectoscope here. These are small dimensions, about 7 millimeter, and with the same 4 millimeter telescope, we just with the seed, that the seed is different, and the seed, the upper end of the morcellator, there is a bevel end that goes to 180-degree to and from movement and chart the tissue, and then by suction is completely out for that also. So the whole myoma can be removed, and you can see the base is almost removed, the myoma of about 3 to 4 centimeter, and you can see the base, and morcellator is clearing the base for that. If it is go inside also in type 1 or type 2 also, it can be done. It can be done without use of the electrosurgical energy sources. So this is another example of this. Now coming to the hysteroscopic tubal cannulation is a cannulation. I'll just demonstrate. People ask about the cannulation set. The indigenous and Cook's is very costly. I use the indigenous cannulation set. There are 3 sets. One is the stillet with the cable. Another is the Teflon wire. The Teflon wire is introduced into that after the stillet is being removed. And this is one example when we find that this is a hysteroscopy view of proximal tubal block by hysterosalpingography. This is the same stillet with the cannulation catheter. You just introduce it, remove the stillet, put the Teflon wire and go inside and just cross it and then put the dye. You can find that the cannulation is complete. It's a very easy procedure. Any ordinary gynecology. Only thing is that the orientation is important. You just go gently, and orientation is required for the assistant also, and just negotiate it. You go closer to that, the telescope closer to the ostium, and then introduce it with that. And therefore, after the end of the procedure, either you can do a selective cannulation, selective chromoperturbation, or you can introduce the Teflon wire. And majority of these are the mucous blocks obstructing at the level of the isthmus or interstitial portion. And therefore, you just negotiate up till about the proximal ampulla or isthmus. The whole thing is done, and these are all rewarding surgery for that. So after the end of the procedure, you just irrigate it with the normal saline, and whole the procedure is over for that. This is another case where ostium is not very well seen. So normally it is as a pit. You just at that time, the negotiation is very, very important. At that particular pit, you just negotiate it and introduce your cannulation catheter for that. That's very important. And after introducing it, you can put the Teflon wire, and you can find that, yes, this is the thing. You go closer to that. A good orientation is necessary, and it's depends on the location of the ostium and your telescope and the operative sheath. It's an operative sheath which is there, and this 7 millimeter operative sheath can do the job for that. And then you can find that, yes, this is the cannula. This is the tubal cannulation set and a cannula with the stillet. You just introduce it and remove the stillet and insert the guide wire, insert the Teflon guide wire. And this Teflon catheter, you introduce it, and it's so designed that it's not going to produce any complications or injury for that. Earlier, we used to have a urologic catheter. The ureteric catheter is very tough. It is likely to perforate because it's a very blunt, tough area. It's not malleable like this particular catheter designed by that. And Cook's catheter is very costly, and we have Indianized catheter. There are many companies who sold. I think PB, I bring from PB, and this is a very good job for that. Now, after introduction of this, we put the catheter. There is a fluid coming out and all that. The other side is already done. This side you can negotiate under laparoscopic guidance. You can see that selective chromoperturbation, the dye didn't come, and therefore we put the Teflon catheter. We put the Teflon catheter under guidance, and this side, the other side, the fluid came, but this side, the right side, we negotiate with that, and believe me, this laparoscopic grasper will guide the tube, and inside you just push it so that whole thing, the catheter can be completely inside. So in a proximal tubal cannulation, this catheter up till this is not required for that, but in multi-segment or where it is a failure, you put this guide wire and now it's complete for that. And then this is the catheter inside the Teflon wire, where you just do the catheterization with a very simple way, and then test it with the dye and blue. I mean, it will come that yes, patency is restored. This is a very rewarding surgery for fertility, and many of the cases who are planned for assisted reproduction, I think do this procedure, and you will be very satisfied that yes, this procedure gives a very rewarding result for that also. This is another case, as I was telling you. This is another case where the polyp, you can see the polyp. This is a polyp where it needs a resection. This is a case of recurrent pregnancy loss. Along with that, she is presented with secondary infertility. So the sonography says that yes, there is a myoma, but here we find a polyp on the left lateral wall, a septum, a large septum, almost around 2/3 of the cavity. And now we are doing a polypectomy, initially doing a polypectomy because nothing was visible for that. And believe me, as I was telling, that this is another case where 4 pathologies there. I have shown one case, there's another case. Second, it's a unlucky patient, but a lucky gynecologist. Say, then doing a same sitting resection of the septum, polypectomy, and after till that time, I have not detected a myoma. But as we go more towards the osteum area on the left side, on the right side, I find on the left side I find that there is a submucous myoma. So the other the left right osteum is very well seen. The left osteum is not seen, and now we can find that yes, this is an area where the myoma, submucous myoma, is seen for that. And this myoma is a very the situation, as I've already told, the location of the myoma is such that the resection becomes little tricky and difficult for that. But once the septum is out, we get a more of space. The septoplasty will allow us to find out more of space, so that we change the Collins knife to the loop, and with the loop electrode we can do the myoma resection. So this is one case where the 4 things can be done: the polypectomy, septum resection, myoma resection, and cannulation. All 3 can be done here in the same sitting to give a complete, I think, surgery for that, so that we don't do an incomplete surgery, whatever we find. But this patient is very, very unlucky to have all these, and the surgeon, I think, must try all its effort to give a best chance for our problem. And this is a thing which you find that on the right side we can find that yes, on that it's a myoma, submucous myoma, on one horn of the uterus. So it's delicate that after getting a space for removing the septum, we can tackle the myoma, and then the myoma resection can be done, so that the complete good uterine cavity can be formed with the tubal patency restored by doing a cannulation for that. This is a broad septum and a very thick septum for that, and therefore these are the cases where electrosurgery can be a better option than the seizure. This type of septum cannot be dealt with seizure. Seizure, only when there is a thin septum, it can be better dealt with. Otherwise, this electrosurgical, particularly the bipolar hysteroscope, will be a better alternative for that, and can do a better job for that. So this is how we just have a resection of the septum. I've already told about if there's a good fibromuscular component remnant inside without retraction, it should come out. If there is still a bulge and all that, you can just resect it by the loop and remove that tissues also. Otherwise, tissue removal is not necessary for that. And that is how you do the surgery in one sitting. You can do that. But after TCRS, we get a space so that we can do this myoma resection for that. This is the area where we find the pinkish area is there, and that is the limit of the septum for that. Now, after we get a little area for going the loop behind the above the level of the myoma, submucous myoma, things becomes very easy, and we can do the job for that. And this is how we do that now. Now the location is such that we can really, it's feasible to enucleate the myoma by putting a loop inside, and I'm changing the loop and just resecting this because I've got the space after the septum resection. You can clearly find that this is a myoma which can be removed very well after the space is being created for that also. Now, coming to the IUCD, many of the cases, the displaced IUCD, we make a blind effort when there is a missing thread for that, and do a repeated DNC for that. But believe me, this is one of the case where you put see that the thread is gone inside. It is just catching the thread by the forceps and bringing it will solve the problem for that. It's a very simple procedure. Within minutes it can be done, and under vision. Most important is things that under vision you can remove it, not blindly you can remove it. And grasping the thread and just dragging it is a very simple affair for that. You just grasp it with the grasping forceps and just bring the whole IUCD out, and this serves the purpose for that. So this is another example of the IUCD, foreign body IUCD removal and a missing thread. By under hysteroscopic guidance, you can remove this. This is another case where there is a displaced loop where it is almost around more than 6-7 years. The copper is already gone, and the thread is inside the uterine cavity. Maybe that it is in the normal position of the vertical arm and the horizontal arm, but still it needs a removal. And this is a multi-load copper device, and this again same thing. It's very easy to put to grasp the thread of the multi-load and then remove the thing and do the procedure for that. The same thing you can see both the procedures, all the three things. It hardly requires any. Only thing is that with the operative sheath, you just introduce your grasping forceps and remove it, and under vision it can be removed for that. So this is a very common thing where a hysteroscopy is of great help to the gynecologist and doing a good job for that. Now this is again another case where some of you must have experienced this. They presented with secondary infertility, and sonography demonstrate that there is a hyperechoic part in the cavity, and this can give a suspicion of osseous material or a bony spicule in a previous pregnancy and or abortion. And this when you put a hysteroscope, you find and you confirm that this is a bony spicules which is there, and it's not the only one spicule. It's a lot of spicules which is there, lot of bones which is there, and hysteroscope can only help it and remove it. And this could be one of the cause of secondary infertility because it acts like an IUCD. So you just catch hold of the part, and piece by piece you remove it, and under vision you can do a good job for that. So this is again a scope for an osseous material, a foreign body which can be removed by hysteroscopy for that. It's like a bone which has come out, as if it's a long bone which is come out and handing over for that. So there are a lot of spicules of bone here, so that the cavity is completely filled with osseous material, and all things completely you have to remove it. Otherwise, your chances of pregnancy will not be there. The second infertility has come with second infertility with one abortion, and cavity should be well formed, and the foreign body should be removed for that. This is how you remove this and complete the procedure. Again, there is a lot of this could be, and it's not abortion, at least I hope that it could be 12, 14 week size. More than that, it cannot be before that. And therefore, we find a lot of bones and spicules inside for that. Maybe she has underwent evacuation and still the bones are left behind, and you remove it by the under vision. Under vision, you remove it and display, and the cavity is well formed after the end of the procedure. And you can find the bones like a long bones, it is appearing like that. And good, all the bones could be removed and could give a good prognosis for this particular patient presenting with secondary infertility for that. So this is not very uncommon. You find quite a good number of cases. I find that these are the cases responsible for secondary infertility. Of course, the sonography can guide you. Sonography can help you when you find a hyperechoic area. Either it's a IUCD or it's a bony material, bony segment for that. And you do that bony spicules, remove that bony spicules completely, and empty the cavity so that the prognosis is very good. And luckily, this patient after that, the next after 2 months, he conceived and already delivered this particular one baby after the second infertility of one abortion. She doesn't have any, one abortion is there. Now everything is, you can find that yes, whole cavity is well formed. There is an arcuate uterus, small septum arcuate, but the whole of the osseous material is out, no foreign body. You check it with that, and these are at the end of the procedure, you demonstrate that these are the bony spicules which can be recovered on that. So this is one indication. Another foreign body. I have a very interesting example in case a young adolescent girl of about 16 years came with foul-smelling discharge for months together. She went she consulted many gynecologists and all that, antibiotics and all that. And I thought I will do an examination under anesthesia. When I did an examination under anesthesia, foul-smelling discharge from one pit, and it's a blind vagina, as if it's a blind vagina in one pit, there is a foul-smelling discharge. And I put this discharge. This is an opening in that. This is an opening where purulent material was coming. Then after dilatation, I put my hysteroscope inside, and this is a hysteroscope inside, and on hysteroscopy I find that there is a foreign body. And then I removed this particular thing. Guided with this guide, I found that there is a metal. There is a metallic portion in the vagina, and this is a plastic, and then again I put a hysteroscopy. I find that another material is inside that. So vaginoscopic examination can give an idea of a foreign body, and this foreign body is nothing but some I think material which the young curious girl has introduced it as a game, and it stayed for months together and years together, giving rise to infection, giving rise to atresia, secondary vaginal atresia, and discharge of pus. So this is a hysteroscopy has helped me as a guide. I introduced it through the point, and then through the point I opened up and removed that foreign body for that. So this is an important thing for vaginoscopy for foreign body, and now the patient is absolutely all right for that. Now this is a case where she presented with repeated bleeding, underwent suction evacuation 4 times. Suction evacuation 4 times by 4 different gynecologists. And ultimately, if the bleeding continues, and every time he does the ultrasound, there is a RPOC for that. I thought we'll do it under hysteroscopic guidance for that. Let me put a scope and find out. When I put a telescope, when I hysteroscope, there is a septum, and the one of the horn, the POC was there. So whatever may be the suction cannula and other methods is not able to approach the part where the product of conception was there. So this was the part of the product of conception which is lying on the right horn, and you just with the grasper you introduce it, and therefore this is, I find that this is the cause of the failure and repeated abortions. Is repeated evacuation by gynecologist, experienced gynecologist is not going to help in all that. So hysteroscopy in this type of situation is very helpful, because the patient is bleeding without, and any amount of medications is not going to help. And every time you do a scan, you find the mixed echogenic area of about 3 centimeter diameter inside the uterine cavity. And even with that, the suction evacuation is not being removed. So because we find that this RPOC is there hidden in one of the cornu, and that is very difficult, and that is the only possibility. Under direct vision, you have to remove it. And this is a real help of the hysteroscopy and all that. I don't say that all cases you do suction evacuation after suction incomplete abortion you do under hysteroscopy, but these are the cases where repeated evacuation is not able to clear it. You think that it could be somewhere else. And at the end of the procedure, I completed the procedure with that. It took little piece by piece of research is an organized product, and I cannot introduce the cannula with that. And this is how, with the grasping forceps, with repeated attempts, I could remove the procedure for that also. So whole cavity, whole POC can be retrieved, and the well-formed cavity, well-formed horn can be seen after the end of the procedure for that. Because it's a very organized product, about 4 months old, it took a long time for removal of that. This is absolutely an unedited video which I'm demonstrating, but I'm giving an example that such things can happen, and hysteroscopy can really serve the purpose for this type of cases where the failure is there, and under vision you can deliver the product of conception very well for that. And this is the end of the procedure where all the products are being removed, and the ostium, the horn can be very well seen at the end of the procedure, that yes, nothing is left behind, and it's the end for that. Now, this is a case where lateral metroplasty. I've done quite a good number of cases of lateral metroplasty, but the results are not very rewarding for that. The indications are either a unicorn uterus, or a T-shaped uterus, or a hypoplastic uterus. The procedure is very simple. Augmentation of the cavity, particularly if you're going for the IVF procedure, the cavity is very small. You just go, and with either with the Collins knife or with the bipolar electrode, you just make a line and the lateral wall of the uterus on either side and broaden the cavity. That is the concept behind that. But I've done quite a few cases, but I can say that it's not very rewarding. I'm not very happy with the procedure and got a success rate with that. I don't claim that, but there are many reports available for lateral metroplasty which is satisfying, particularly for T-shaped uterus for that. I'm convinced that in T-shaped uterus it's very good, but it's not very rewarding for the cases like this, and unicornate uterus or a tubular uterus, post-myomectomy uterus. All these could be one of the indications, but the results are still $1 million question and a big question mark for that. So on both the sides, you just give 2 lines, and the depth slowly you go, because if you go very deep, there is a risk of injuring to the uterine artery. So so that is why the precaution has to be taken. Go very slow, gently, and as far as possible, don't go more towards the uterine artery. Very laterally, uterine artery is there. At least 5 millimeter depth is enough for that. Don't go more than that, and that gives a reasonable augmentation of the cavity of the uterus for that. Endometrial ablation and resection. I think we have done earlier, about a decade before, quite a good number of cases of endometrial ablation resection. Indication of I have already told that AUB, young age, wants to preserve the uterus, and instead of removing the uterus, you ablate it, because you remove the endometrium for that. So the patient selection and preparation is important. The technique is, we do it with resectoscope technique. The alternate technique, I have told that the thermal balloon ablation is there. The controversy lies in one factor, is that if at all you are not able to completely remove, one chunk of the endometrium is kept behind, that gives rise to I think hematometra, partial hematometra, and terrible dysmenorrhea. There's one. And second is that if at all that chance of malignancy is going to happen, that is not detected earlier. And that is a big question mark for which the debate still continues whether to go ahead with this resection or some of the alternative methods for that. Hysteroscopic sterilization, again, I am told that it's very difficult to clip the tube from outside than from inside. So normally the failure rate of plugging the, if you plug the ostial end, the failure is more than if you're going to clip it from above. So electrocoagulation, cryocoagulation, about 80% failure will be there. Non-destructive occlusion device like and mechanical device like the Assure is there. You can use it, and a lot of trials have been there with Assure. And intratubal device like HAMU, injection of chemicals like quinacrine, gelatin, resorcinol, formaldehyde, MCA could be there for that. But ultimately, it is yet to be rewarding for that, and it's not very reassuring, excepting Assure, which has done a lot of publication, but the results are not very rewarding for that. Now, coming to the complications in the last, early secondary to uterine distension, I've already told, if you are using the carbon dioxide, we are not using the gas, only the liquid medium can give rise to anaphylaxis, fluid overload, and dilutional hyponatremia syndrome, non-cardiogenic pulmonary edema for that. And secondary to the intervention like cervical tear, uterine perforation, bleeding, thermal injury will be there. And late in like infection, bleeding, synechia, pregnancy, and cancer, of course, I've already told for that. So these are few examples of complications faced by me. I have done that personal cases, which I say that Mrs. X, case of RPL, planned for diagnostic hysteroscopy and cavity evaluation, diagnosed as complete uterine synechia, and second opinion sought. That I was showing the same case. It was a false passage. So how to minimize and prevent false passages and how to recognize. The same case which I have already shown it. The same case is initially it was thought that it's a synechia. Then the second opinion, when I came and found out to my trainees that yes, you put the scope little down and look at the top. There is a area black hole is there, and that black hole has given me a guide that yes, it's not the cavity is above. And this is a case which I've already shown it. And this is in that case it's preventable to do the vaginoscopic examination, and vaginoscopic hysteroscopy can be an alternative. So improper dilatation is the factor for that. Visibility and orientation, change of direction of scope, double channel seats, and gentleness with negotiation without resistance is the key for that. And no additional treatment is necessary. Once there is a false passage, it's not gone for a perforation, nothing is to be worried about that. But only thing is that it could be avoided. You can use the misoprostol to avoid that, or do a vaginoscopic hysteroscopy to avoid that. Situation 2, Mrs. Y, 25 years, primary infertility 5 years, planned for DHL, DH cavity visualized, and after visualization immediately collapsed. So when suspicion, when you are not able to see the cavity after introduction of the first suspect that there could be a perforation for that. And then immediately it was confirmed, and there was a fundal perforation, and there the laparoscopy, concomitant laparoscopy diagnosis, and itself the bleeding could be controlled by just coagulation. And the only problem is that the dye test could not be done. But in a small rent, you grasp with a grasper, laparoscopic grasper, you just occlude the rent and can do a dye test to find out that yes, tubes are patterned or not. And of course, a coagulation, and then subsequently you can be, this is a site of weakness, could be giving rise to a rupture in the latter part. But normally with a small bore dilator like 4, 5 or 6, it doesn't happen. After this procedure, you just coagulate it, clean it, and then subsequently many of the patients do have a good favorable outcome for that in pregnancy, and complications are less. But still there is a weak point for that. But laparoscopy can help you in detection as well as managing the particular case. But this could be prevented as far as possible. Dilatation should be very gentle. A 0.5 millimeter dilator should be used, and preferably the misoprostol can prevent the use for that. And don't push it. Many things is that always dilatation, you just have a gentle dilatation, and wherever you negotiate, you go it. Wherever there is a resistance, you don't go it for that. and acute antevoted or acute retrovoted could be a problem for that. But basic philosophy is that you just don't push it and or negotiate it, automatically it will go. And this is a better thing that and under anesthesia is much better. Office procedure, again there is a problem, because office procedure we do not use the dilator, you use the resector. The whole thing is the telescope and the sheath, and the telescope and the sheath could produce also a perforation for that, where there could be a problem. You have to shift to the OT for that. Situation 3, Mrs. C, 30 years, primary infertility 8 years, case of prime bilateral proximal tubal block, plan for hysteroscopic cannulation. Teflon tip perforated. Then you see that this is a case where the cannulation is attempted. You can see from the video what has happened for that. So normally we do that hysteroscopic cannulation immediately. This is the outer the cannula sheath, cannulation sheath, and through it the Teflon sheath has to be introduced after removal of the stent. And the same thing we did it, and you can see that here the procedure is absolutely negotiated. There is no problem here, and main thing. So therefore, the characteristics of the Teflon is important. It must be there. You go and negotiate with the laparoscopic guidance. We do it, and you can see that the cannula. I'm not able to see the cannula. The Teflon, the cannulation catheter. Teflon catheter is not seen. Now it's just negotiating the cornwall and just negotiating the isthmus and interstitial portion, and now we can find that yes, there is some. I feel that there is some difficulty in negotiating that. So this could give a hint that this is in a different plane, because it's easy to, if cannulation is easier, then it would go easily. There could be some. I suspected that there could be some fibrotic thing, some organic thing, but it's not very obvious, because outside it looks absolutely normal. It's not a pathological tube, and maybe that the negotiation, there is a little problem for that. So it's a fault of the surgeon who has negotiated with that, and we find that yes, the whole of the tube, it has not come out. Now you can see that it has perforated at the junction of the isthmus and ampulla. So this is a very, very atypical case which I find, and this is my own case. I have done the perforation, and but still I didn't lose patience on that. I just withdrawn this Teflon catheter, and withdrawn is completely, straighten the tube, and again negotiated and try to negotiate the original thing, because that was the area of perforation. Because I had not straightened the tube, it has not gone through the right direction for that. And once I have negotiated it, it has now gone through the right direction. You can see that the cannulation catheter has gone, and I have negotiated the whole of the tube, and then I could find that yes, it is up to the level of the isthmus. It could be detected. The whole cannulation could be performed very well with this. Now it has emerged out, and the only thing, I was very happy that yes, I could do the procedure with that, and subsequently the dye test, I just sealed it. I just sealed it with the grasper and did the dye test, and the dye test becomes positive with a small opening for that. And that is one of the complications which you must be very, very careful. The dye is positive, it can come. You have to just plug it, the part of the rent, small rent, because it's a Teflon, very, very small, minute rent, and it will seal. And it's a very small rent, it could seal, and the patient conceived, and very well. I was expecting that they will land in ectopic pregnancy, tubal pregnancy, but still the patient, I think, is very lucky. And this is a case where patient is persistent vaginal bleeding following TCRS, 8 hours following surgery. 8 hours following surgery, she is a bleeding. And normally in TCRS, in the vascular septum, normally at the same time while doing a cutting current, if there is a bleeder, you change into the blend current or coagulation current and touch it. That is the direct control of the bleeding. Then putting some
tamponade or something like. I don't believe in that. But these are the cases where septum can cause this. But you again do that, you do a hysteroscopy, again find out the bleeding vessels, and then coagulate it also. So this can serve. Under direct vision you can do it, or a pediatric follis you can introduce it as a tamponade for that. But best thing is direct visionation. Prevention is always best for that. This is another case, Mr. Saab, primary infertility 5 years, planned for diagnostic hysteroscopy. And this is a view of the hysteroscopic view. In this particular case, you can, when I put a telescope, when I put a hysteroscope, I was surprised to find that there is something abnormal, something fishy inside the cavity. And immediately I could say that I'm going through the early pregnancy. And of course, the patient gives a history of a last menses 15 days back. I think that's a very good thing. I always say that take a proper history. If you're giving date 2 months later, you must again verify that they exclude pregnancy for that. So this is a pregnancy sac which is there, and you can see the embryo through that hysteroscopy, and the rent could be found out with that. I confirmed it that this is a case of early pregnancy. The gestational sac is well formed inside the cavity, and I was really sorry that this done. I checked it. She was having a menses, but it's not a normal menses. It's just spotting, and that could be pregnancy with that. And I lost hope in that particular case. Immediately, I canceled the procedure. But this is a case where the case was detected, and pregnancy continued. I gave it tons and tons of progesterone, rest, prayed God that this thing, uneventful antenatal and intrapartum period. Fortunately, the patient has a continuation of the pregnancy with the and a male baby doing well about 4 years back. God is great. And therefore, miracle happens, but miracle doesn't happen always. Miracle happens at times. And I was fortunate, I was lucky. God has blessed me that I had done the blunder, but God has given me the reward for that also. So they conclude hysteroscopy. These are some basic and hard facts. Every surgery is easy and every surgery is difficult. It's the surgeon that makes the surgery easy or difficult. Gone are the days when hysteroscopy was searching for indications. We have reached a stage where indications are in search of hysteroscopists. There is a dearth of hysteroscopists. I appeal all the gynecologists. And if you want to designate yourself as a gynecologist, do become a hysteroscopist. And all gynecologists must be hysteroscopists and all that. A very simple procedure. Even if diagnostic, gradually go by phase manner. Hysteroscopic spectrum has broadened in view of improved visibility, efficient distance and system, newer and refined instruments, efficient power sources, and updated skill of surgeons. Orientation is the key to surgery in hysteroscopy. And hand-eye-foot coordination is the cornerstone, as I'm repeatedly told that this is the thing. So although hysteroscopy complications are uncommon, they're potentially severe and unrecognized. Unrecognized give a fatality for that. Prevention, early recognition of unrecognized complications, and immediate management of the basics of hysteroscopic surgery. Non-surgical complications such as anesthetic complications and complications due to distance and media more often encountered than the procedural complications. So if you want to master hysteroscopy, the key issues: understand reproductive anatomy and physiology. Expanding horizons of scope and scopy, you must remember. Understand your team and tool. Acquiring the techniques and skills. Minimize complications and maximize the results and all that. And you must know about the reproductive anatomy and physiology. You do good history taking, pelvic examination, sonography, and examination under anesthesia. It is not the technology, it is the tech and the touch which is important. Allied thing, you make a decision for that. And therefore, if you do that, expanding horizons of scope of scopy from diagnostic to operative, from fertility promoting to contraceptive techniques, from benign to malignant, and from simple procedure to more complex procedure for that. So understand your team: anesthesia, fluid balance, circulating nurse, endoscopic technician, dual procedure and assistance you must do it, and acquire a skill under preceptorship. Pre-op planning, level of learning, method of learning, seminars, workshops, teaching videos, working with tissues, simulators, tutorials, preceptorships, and hands-on training, credentialing. And that is the purpose of this surgical skill transfer e-Gurukul program, which I share some of my surgical techniques. You are the best judge whether this is and a stimulus to you. It's not a learning. I'm not giving additional knowledge to you. I'm just stimulating you so that you can be a better hysteroscopist than many people, including me. So orientation, coordination, understanding energy sources, new innovations and applications could be there. But ultimately, the theme is minimizing complication and maximizing results and get best out of the technology. And if you devote that, I think you can be a good clinicians and a surgeon par excellence and can excel all good surgeons for that. Oh, Francis Bacon has told, not to contradict and confute, not to believe and take it for granted, not to find and discourse, but to weigh and consider. You are the best judge, you weigh and consider. And then you can say, see one, do one, and teach one. It's so simple that you can be a master, mastering hysteroscopy. Thank you very much, ladies and gentlemen, and my viewers, for giving me this opportunity of 11th episode. And thanks our Juventus academic partner for their really invaluable support and academic partnership and a teaching partnership for my viewers, benefit of my viewers and my fellow gynecologists. Thank you very much.
Thank you very much, sir, for your such a nice and lucid presentation as always. You keep the audience spellbound. Sir, there are quite a number of queries which have come. If you allow me, I can share a few of them.
Yeah. If you have a time.
Yeah. So, sir, the first one is from Kuch Bihar. Sorry, from Bhubaneswar. This Dr. Sanjay Chand Ray. He's saying, what are the complications of hysteroscopic surgery?
I've already told that hysteroscopic surgery could be related to anesthesia complications, could be related to the medium, distension medium or distension procedure, and operational or procedural complications starting from the injury, tear, perforation, and it can go across. Electrosurgical burns can be there also, and the procedural complications are less than the anesthetic as well as the distension medium complications. So you must be vigilant about this fluid balance and all that.
Sir, Dr. Madhusudan Sahu from Lake Town is saying, what's the office hysteroscopy?
Now,
And
I've already told office.
And which ablation in AUB?
Yeah, office hysteroscopy is a name. Globally, is accepted by the hysteroscopic societies also, and lot of people are in favor of office hysteroscopy. This is basics is that I've already told office hysteroscopy name is a little given name for marketing procedure for that. So office hysteroscopy is a procedure where it can be done in your OPD setup and without anesthesia with small dimensions or small diameter of hysteroscope. You can do a diagnostic and you can do a minimum operative procedure like a septum. You can do it, small septum you can do it, small myoma you can do it, or the removal of the copper T or IUCD. The common procedures you can do it also for that, but major procedures you cannot do it with that office hysteroscopy, and it depends on the patient. You have to counsel more. In my practice and all that, I get a lot of problem. My patients are not really willing for office hysteroscopy because the position itself is a problem. Little discomfort will be there for that, but at the same time the anesthetic complications will not be there, and you can do for a minimum diagnostic and for minimum surgery you can do it also.
Right, sir. So there's a query from Chennai by Dr. Vijay Lakshmi Kandaswamy saying that what about a large submucous myoma? How many sittings will be required to do them? Then how will we know that our septum resection is enough? And third part is that is it mandatory to do the lap after septum resection? So three parts of our query.
Thank you, Dr. Vijayalakshmi. I find that till you have not missed any episode of that, as far as I remember, because you are really very, very curious and all these e-Gurukul program. Thank you very much from my side. First of all, the myoma size. The size of the myoma is important for that. Sonographically orient it with that. The size of the myoma, the location of the myoma, and the number of the myoma. So you want to know the size of the myoma, maximum size. And sitting. I have told that beyond 5 centimeter, usually one single sitting little problem for that. You can do the procedure, but it will take a long time and fluid absorption will be more for that. That will be risky. So for that purpose, we postpone. And in that case, repeated sitting is much more better. And as far as I remember in my practice, in one case, I have done 3 times. One of the wife of a police IPS officer, and second infertility with menorrhagic cycle, large myoma, and there the is it audible?
Yeah, it is audible, sir.
So large myoma. So I did it purposefully in 3 different sittings and could do the procedure for that also, and I got a rewarding result for that. So believe me, the time is important. If it's taking a long time and the fluid absorption is more, you stop that procedure, number one, irrespective of the size of the myoma. And size of the myoma more than 5 centimeter usually requires repeated sitting. Mainly 2 sittings at an interval of 4 to 6, 8 weeks will be enough for that. Then second is about the septum. This is a very common question when you know that the septum resection is complete. Now the septum resection is complete. I have told that there are only the one thing is that the panoramic view of the 2 ostium is one aspect. Second aspect, you find that yes, there will be bleeding. The area will be little pinkish rather than whitish, so that you can know that you have gone to the muscle. And of course, if you have a preoperative assessment of the fundus, particularly the muscle tissue for that, that will be much more better. You can avoid the laparoscopy. Or in the initial phase, you can put a laparoscope and find out the reflections, the color, and you can find that which area you are going, which area you can see the more of the light, and say that this area is thinner. So thickness of the muscle can be approximated by laparoscopy guidance, but not in all cases for that.
Right, sir. So, sir, now there is a query from Katak, Dr. Manoranjan Mahapatra. He's asking, like, can we perform diagnostic PTC in same sitting as during diagnostic strain, the cavity and the cannula use over dilate the cervix? Your tips, sir.
Well, diagnostic and therapeutic can be done in the same setting also. There is not a problem, because in a cannulation, you are using the operative sheath. It's not a resectoscope, which needs some more of dilatation for that. So here, 7 millimeter, you can use it for that. The operative sheath, the same thing, but you have to counsel it before. What we do in a diagnostic hysteroscopy and laparoscopy, DHL, there are some cases we suspect we counsel beforehand that the operative procedure is necessary, so that she has to be stayed overnight for that. So at least cost factor and the duration, all these has to be counseled for that. So those are the cases concomitant therapeutic procedure can be adopted. There is no problem in doing that. If you're doing it the same procedure, you can do the procedure, and the cannula with the operative sheath can be very well negotiated with the same sitting for that.
The second part of his query is like, if perforation occurred during any procedure, then when to do the second sitting? Any specific precautions in second sitting?
Now, suppose there is a perforation and you find that your investigations is incomplete. You are not able to do the tests, the right test in a diagnostic, or you are doing a procedure of septum when there is a perforation and all that. Normally, what happens in a septum, the perforation is more likely to occur at the end of the procedure, and provided it's not there with the dilator. If it is with the dilator, it is in the beginning of the procedure, where you can see, and by laparoscopy, that there is a rent, and you can seal it with that, and a minimum period of gap of about 2 months. I recommend that 8 weeks period is an optimum period for a healing, and then you can do the procedure for that also.
And the third part of his query is that DH and EB in PMB. So any tips to reduce possible cancer cell spillage transtubal?
Yeah, that is a question I think oncologists always say, that whether in a post-menopausal bleeding, whether hysteroscopy is to be done or not. Because if there is a endometrial carcinoma, that will go and spill it for that.
But ultimately, how do you diagnose? Majority of the cases of postmenopausal bleeding are either you don't find anything, senile endometritis, or in a case of hyperplastic endometrium, I find that the polyp is the major thing for that. So once you find that there is a suspicion, only thing I will just recommend that don't do it and for a long time for that. Quicker finish it, and as soon as the diagnosis is complete, you just stop, so that you don't prolong the procedure for longer time for that. So that is the only thing I will recommend. Otherwise, there is not a problem.
And sir, there's one more query which is finally from Dr. Atul from Champa, saying, sir, is there a chance of complication in bipolar NS resectoscope setup with Collins knife or loop? How much the amount of NS can be used in one setup, and what's the current setting?
Well, as far as the volume deficit is concerned, when you are using the normal saline, all the available data shows that the limit is 2.5 liters. If there is a deficit of 2.5 liters, the chances of pulmonary edema is more. And if you're using the glycine, 500 ml, you must cautious. 750 ml must be very, very cautious. 1000 ml, you abandon the procedure. So I would recommend that, yes, 1500 ml of normal saline. I think that is important. And it is not the amount of normal saline, it is the duration which is important. How within a short time, if 1500 ml also goes behind, it goes right to pulmonary edema for that. So that is the purpose for which. Don't think that by doing a bipolar setup, you are completely safe. That is my thing and all that. I have also found many cases of pulmonary edema because of the bipolar. The only thing is that it is not that fatal as compared to glycine hyponatremia or ammonia toxicity, where it is absolutely fatal. But here it is a treatable, but be cautious about that. The timing is important. The pathology is important. If you are going for the myoma resection, it's more common, but it's not for the septum takes a long, short time, and this is a fibrous thing and all that. The myoma becomes vascular, more of vessels are there, and that's why. Therefore, I always say, if you are going for a myoma resection, don't do a myoma resection without endomet, because even with the gravity, even with the conventional thing which I have demonstrated, cheaper, you do not know how much is being absorbed for that also, and what is the pressure. So therefore, a controlled suction irrigation system like endomet is much more preferable for that.
Dr. Maya Padi has just commented that excellent presentation, simple, lucid, and lovely visuals.
Thank you. Thank
And
you.
Dr. Poonam Gupta from Varanasi, she is asking for you to provide your phone number if possible.
Just note down 99374 96591. 99374 96591. You want to talk to me? Good. Thank you very much. Thank you very much.
Right, sir. Thank you so much for your presence, sir. And it was really lovely, lovely session, and we all enjoyed it thoroughly, sir.
Thank you. Thank you.
Sir.
Thank you.
Thank you very much.